attitudes and intentions about vaccination for over 20 years. And today he's going to be talking about a tailored video intervention to increase HPV vaccination.
Thank you, Annie Laurie, and thank you to the organizers for inviting me. I want to just quickly acknowledge my co-authors, and actually the first author, Brian Dixon, who wasn't able to come to the meeting to present, so I am Brian Dixon for the time being. But it was a great team of colleagues that helped to get this research done. Here are some disclosures. And the source of the funding, this was sort of a unique funding stream that we had at our Regan Street Institute, which is independent but affiliated with Indiana University. It's an Informatics and Healthcare Research Institute, and they partnered with Merck to help to fund a series of projects, and this is one of them. So the objectives of this study were to assess the effects of a point of care, so in a clinic, of a video encouraging the receipt of HPV vaccine, basically the first dose for those who hadn't started, or the second dose or third dose. We did this study when it was still 3 doses. So that was basically the overall goal. We did this study in clinic settings. So this was implemented in 5 pediatric clinics run by Eskenazi Health. Eskenazi Health is our county, Marion County, which is Indianapolis, health provider. So it's an urban safety net provider in metropolitan Indianapolis. The targets were parents of children 11 through 17 years of age who had not received HPV vaccine or had not completed the series. So basically the design of the study was that the intervention involved the delivery of an informational video via a tablet, and this was called by the company that developed the tablet Theo. There were 5 clinics. We randomized 2 clinics to the intervention, and 3 clinics were randomized to a control condition where there was no tablet. All 5 clinics, they're sort of laboratory clinics, or they were laboratory clinics in which a unique clinical decision support system called CHICA was integrated into the electronic health record. So these are clinics, they're fully functioning community-based clinics, but they were optimized to do all sorts of interesting research studies, not just this one. This decision support system was able to interact with our state immunization information system to retrieve and deliver information about the child's HPV immunization status. So it's a sort of unique kind of interaction. The study went from October 2015 to May 2016. So this is sort of a schematic of the intervention workflow. Basically, that decision support system, CHICA, retrieved information both from the EHR and from the immunization information record, which in Indiana is called CHIRP. So I kind of like the idea of Chica talking to CHIRP. Just me. But, so then Chica would then alert the medical assistant that there was an eligible patient, and they could deliver then the tablet to the parent of that patient. They would enter a unique identifier and also set up the program depending on whether the patient was male or female and whether they were a first dose or a subsequent dose patient. The patient and parent would then view the video before seeing the physician. So we had a pre-video survey, which we used as sort of a tailoring kind of approach. We would say your child is due for HPV vaccine today. Are you planning to have them vaccinated? So they were given 2 choices, yes. And if they said yes, sort of a little bit what Jasmine is saying is if someone is already intending to vaccinate, the only thing we can do by giving them information is to raise some questions potentially in their mind. So we really, don't mess with success. So we would not make them watch the video. But then we also didn't want to have a no option. We didn't want parents to kind of take a stance and say, no, I'm not getting my child vaccinated. So the other option was, I would like more information. So if they said they wanted more information, then they saw the video. And they either got the first dose or the subsequent dose video. Topics covered in the video. So these weren't really, the tailoring occurred at that first level. These were not necessarily tailored to particular concerns. The videos were sort of similar, whether they were first or subsequent dose. The person narrating the video said your child's due for the first dose. If it was a first dose video, there was sort of a normative statement about how it's routinely recommended, and many, many children have gotten the vaccine. HPV causes cancers in men and women. It's safe and protective, and it works best when given early. This is kind of a shortened version of it, but for the second or third dose video is very similar, except we had a final statement to promote behavioral consistency. So we'd say, you got your child the first dose, or you started the series, it shows that you want to protect your child, finish what you've started, and fully protect your child by getting the next dose. So these are just very simply some of the results here. So this is what we'd call intention to treat. So we just looked at comparing the clinics that got the tablet to those that didn't. So in the control clinics, 50.1% of the eligible children and adolescents received a dose of HPV vaccine within 2 weeks of the visit. And this is based on CHIRP, the Immunization Information System records. In the intervention clinics, 64.8% of eligible children and adolescents got the vaccine. And that was a 14.7% effect size, which is reasonably strong for these kinds of studies and was statistically significant. So that was encouraging. What's interesting, so we also did sort of a per protocol analysis within the intervention clinics. So there are a couple of things I just want to say about this. So one is, you can see that 75% of eligible parents did not get the tablet. So this is a problem we face in busy clinics. And there, if we have time, I can explain some of the unique problems. One of which I'll just say is that the Theo tablet was based on an iPad, and the existing tablets that were used in the clinics were Android. So the poor medical assistants had to distribute to eligible parents 2 different tablets. I mean, and there was no way to kind of, that's something that could easily be overcome, but the company that developed this programming was set on using an iPad. So that's one of the reasons. But so the 75% of parents who did not get the intervention within the intervention clinics, 52.8% of those children and adolescents subsequently got vaccinated. Those who did get the tablet, again, we're talking about relatively small numbers here, 25%, 78% got the vaccine. So again, very encouraging. It's not the final word because of a number of issues, but it was very encouraging to us that suggested that this video intervention could, at the point of care where the vaccine was offered immediately afterwards, could have a fairly strong effect on vaccine uptake. And that's what I just said. So I will, I got ahead of myself, sorry. So I'll stop there, and I guess we'll take questions later.
Okay. Thank you, Greg. So our next speaker is Dr. Parth Shah. He is a member of the Hutchinson Institute for Cancer Outcomes Research. He brings his training as a behavioral scientist and as a pharmacist to bear on how to study how to improve clinical practices. Today, he'll be presenting on a study to understand how to best address parents' communication needs, again, beyond that initial recommendation.
Hi, good morning, everyone. Thank you for that introduction. So I'm really pleased to present some of our research that we conducted in a paper that we published entitled Questions and Concerns about HPV Vaccine, a Communication Experiment. In this talk, I'll discuss findings from this paper that constitute a national online communication experiment to understand characteristics of HPV vaccine messages that can help increase parents' confidence and motivation to get their children HPV vaccine. Before I jump into our study, please note our disclosures. The study was funded through the CDC, but the funders played no role in our research and choices to publish. Dr. Noel Brewer, who is the principal investigator on the study, has served on paid advisory boards for Merck, Pfizer, and GSK. All other authors have no financial disclosures to report. So a little bit of background. Recently, our group identified over 250 messages available online to aid providers in communicating with parents about HPV vaccine. Okay. However, little research has focused on which of these messages reduce hesitancy and why. So to address this gap, we conducted an online communication experiment with parents of preteens and teens. The survey randomized parents to 7 common topics about HPV vaccine, such as vaccine safety concerns. The topics that parents were randomized to were ones that they indicated that they wanted to learn more about from their child's healthcare provider. For each topic, for each HPV vaccine topic, I'm sorry, the timers are on. For each HPV vaccine topic, parents watched 4 videos of pediatricians delivering messages about that specific topic. And then after watching each video, parents were asked, Are we good? Okay. Okay, I'm sorry about that. So after watching each video message on that particular topic, the survey asked parents to rate their confidence in HPV vaccine and motivation to get their children HPV vaccine after watching each video. The survey participants were a national sample of parents of children aged 9 to 17. Children either had not started the HPV vaccine series or had gotten their first dose of this vaccine. So let's dive into the results of the study. First up, I want us to take a look at what type of information parents wanted from their child's healthcare provider. In the first column are 7 common HPV vaccine topics. Overall, we see that most parents wanted to learn more about HPV vaccine. When we asked parents which HPV vaccine topics they wanted to learn the most about, we found that about 75% selected 3 topics: safety and side effects, diseases prevented by HPV vaccine, and the age to start the vaccine series. Also note that a plurality of parents selected wanting to learn more about safety and side effects. Next, we wanted to see how parents' confidence increased after being exposed to the video messages. Across the bottom, or the x-axis, we have the proportion of parents who reported being more confident in HPV vaccine after message exposure. And then along the sides are the 7 video message topics grouped into the larger categories. The top one being lack of knowledge about HPV vaccine, and the bottom one being messages that address concerns about HPV vaccine. So first in blue, we see the responses of parents of children who have not started the HPV vaccine series. Generally, parents who are randomized to topics that address lack of knowledge report a higher confidence compared to parents who viewed messages that addressed concerns. Of note, we see that messages about diseases prevented by HPV vaccine and vaccination for boys and girls perform particularly well for this group. Also to note that parents who were exposed to messages about safety and side effects concerns had one of the lowest increases in their confidence. in vaccine. Now, compared to the parents in orange, the parents of children who initiated the vaccine, we see that across the board, all the messages seem to work pretty well, particularly messages about the age to start the vaccine series. In our next analysis, we coded all 28 messages that we tested to their specific characteristics that they had, and looked at how these message characteristics correlated with parents' motivation to get their child HPV vaccine after message exposure. To test this, we conducted a multi-level linear regression. In the table that's shown here, the first column are the message characteristics. The second column will be the unadjusted means for the categorical predictors, and the last column are the adjusted regression coefficients. So first, we see that parents exposed to messages that address lack of knowledge reported higher HPV vaccine motivation compared to parents exposed to messages that address concerns. Next, parents exposed to messages that required higher reading grade levels and that were longer in length reported higher motivation. Third, parents exposed to messages that mentioned cancer prevention reported higher motivation compared to parents exposed to messages that did not mention cancer prevention. And finally, parents exposed to messages that expressed urgency, that is, encouraging vaccinating today, reported lower motivation compared to parents exposed to messages that did not express urgency. So taken together, through this experiment, we identified some general communication principles that providers can use to address HPV vaccine hesitancy. First, providers may want to include information about cancer prevention. Videos, messages that relay cancer prevention information led parents to report higher motivation to get their children HPV vaccine. Second, expressing urgency to vaccinate when addressing hesitancy may be counterproductive. Urgency is important when you first bring up vaccination and when you're recommending it, but expressing urgency when you're addressing a concern, when a parent is hesitant, may make them feel inappropriately rushed or that their concern is not being taken with care. And finally, providers may need to prepare to engage in longer discussions about HPV vaccine when parents express hesitancy. Brief messages may be sufficient to bring up the topic, but providers need to be prepared to have a longer discussion when a parent expresses a concern. So our study provides improved messages for the announcement approach, a method for recommending HPV vaccine developed by Dr. Noel Brewer and colleagues at UNC. We suggest providers use these research-tested messages with hesitant parents. So in the first step, the announcement step, a provider starts with an announcement for HPV vaccine. It sounds something like this. Now that Sophia is 12, she is due for 3 vaccines. Today, she'll get vaccines against meningitis, HPV cancers, and whooping cough. But say a parent hesitates after the announcement. The provider should then connect with the parent on their main concern and show that they're listening, clarify using research-tested messages, and then counsel the parent to make a clear recommendation for vaccinating. The clarify step here is where a provider would use a research-tested message from our study. So of the 28 messages that we developed, here we provide 7 example messages that were refined for the clarify step through our study findings. As an example, I'll read the one for age. Kids respond more strongly to HPV vaccine when they are younger. This may give them better protection against some cancers. You can find our research-tested messages from this study along with other evidence-based tools for HPV vaccination that our team developed at hpviq.org. Before I wrap up, I'd want to acknowledge my co-authors at UNC and Penn State. Thanks for your time, and I'm happy to take questions during our panel discussion.
All right, so before we go to the question and answer period with the panelists, we want to encourage you to process what you've heard today with the people at your table, or I guess that would be your cabin. So for the next 15 minutes, please engage with your cabin mates around the 4 questions that are going to be up on the slides. You also have these questions on a printed handout at your table, and if you're like me and are a note taker, you may already have started generating some questions. During this time, our panelists will be circulating to listen to hear what you have to say about the implications of their research for your work. We'll reconvene back here in about 15 minutes and have a few minutes for questions and answers. If you're listening via live stream, you're encouraged to think through these questions for yourself. All right, ready, set, discuss.
For those watching on the live stream, the questions are, what are the implications for your work and your stakeholders? What was your aha moment during this panel? What are the challenges to implementing these interventions and strategies? And what actions do you need to take after hearing this panel? Thank you.
I'd like to ask the panelists to come back up. So we have a few moments to come back together as a group. And as we were circulating around, listening to people's aha moments and what the implications of their work were, of these findings were for your work, there's some themes that we heard. Some were around the simplicity of messaging and how that's important, about this sort of elegant, simple recommendation, and how even addressing parent concerns might be able to do that. One of the things that I heard at multiple tables was this idea of, well, is this ready for prime time? Are these interventions ready to be put in the field? And so I'd like to just start off with a quick question for the panelists about, what do you think the implications are for practice at this point in the rollout of these interventions?
You want to start?
Sure. So I think with the particular messages that we looked at in our study, I think they are ready to be tested. I mean, obviously they can be refined even further, especially when we're thinking about select populations. If these messages work among racial and ethnic minorities, are they culturally sensitive? Also, whether these messages actually help promote on-time vaccination among hesitant parents. I think that is actually a very clear next step, because our study was an online experiment, and it's now to actually do a trialist design and actually take it into clinics and see how they actually perform in behavior change.
Others?
So I think there's tremendous tension between, with any kind of research, because there is a lot of pressure for us to implement in the real world, and I think that's really important. At the same time, it's really important to make sure that what we're implementing, we're not just spinning our wheels. So I do have concern, it's a difficult balance, and I have concerns about it. In terms of the intervention that I reported on, I think there are aspects of it that could and should be implemented. And I don't think we always have to wait for the final empirical evidence. I think sometimes there's good clinical practice that has maybe only partial empirical support. We need to keep, I agree, we need to, the testing and evaluation needs to be ongoing, because as we see with science, which distinguishes it from religion, is that we continue to question it even after things have been implemented and maybe have been standard practices for decades. We get more information and it tells us, that we need to make some adjustments. People often see that as a reason to distrust science. I see that as a reason to celebrate science because it's willing to say, we were wrong, we need to make some changes, let's try this. So I guess that's a long-winded answer.
Thank you, Greg. This tension was another thing I heard across tables, especially thinking both on something you said and that Jasmine brought up, and that's this possibility of what we're doing having an iatrogenic effect, that we could actually have a negative effect. Are there other things you'd like to add into this conversation?
You know, us developing behavioral interventions, communications interventions is no different than us developing treatments, drugs, et cetera. Just because we've completed a clinical trial doesn't mean that we don't continue to evaluate it. Now, does it mean that we don't make it available to the general public? No. But it means that we need to be responsible in thinking through and helping make sure that healthcare systems and others understand we need to continue to evaluate it. That's what whole post-marketing surveillance, drug registries are all about. There's no definitive set of evidence that will tell us yay or nay. But if we do and continue to do our science, help educate folks about the importance of doing continued evaluation, sharing those data back with the developers and other healthcare systems, then we can really, accumulate the massive evidence that is necessary so that we continue to improve upon our interventions. They don't just are static, they evolve, and we need to acknowledge that evolvement both from a drug perspective as well as from a behavioral intervention perspective. And so you guys are our partners in this, in that we want you to put them out in the real world settings, but we want to continue to work with you to evaluate to make sure that we aren't seeing negative effects.
So because the conversations were so robust at the tables, we did take a little bit of extra time with that and only have a minute or two left. But I think jumping off from what Jasmine just said, we'd really love to hear from one or two people at your table about what are the actions that you feel like you need to take after hearing this panel or that you would like to hear more about.
Hi, I'm Jason Turk. I'm a pediatrician in Texas. I think that there are a lot of exciting possibilities that are suggested by the research that you all have been doing. But I also think that it's going to be even more effective if you can put that truly in the context of the visit between the child and the physician or non-physician provider that they're seeing. And to the extent that you could literally put the physician as the talking head in your videos, if there was a way of having that person do their own videos and plugging it into the modalities that you are talking about, then that's going to feel like to the family, that's my doctor talking to me about this, as opposed to something that maybe seems a little bit out of context. And so I look at that as a potential opportunity in moving forward.
Thank you. Time for one more. Anyone else have a comment or a question?
I started to ask this question to Jasmine. This is Judy Klein from Unity. I think timing is everything, and we were talking about that at our table, that people are obviously going to absorb the information when it's relevant to them, and that was something that you acknowledged with your app. Have, I guess any of you decided or thought about how to best target the message to, the vaccine hesitant person within, the area that they are seeking care or seeking information?
I think that the kind of behavioral interventions we're talking about, or messaging, communication, are probably most effective when they're delivered temporally close in time to when a vaccine can be delivered. I think there's a lot of erosion in the power of these messages over time. So I think as much as possible, we should try to evaluate and deliver and evaluate the messages in settings where the vaccine can be immediately administered.
I think obviously timing is really important. I think about the last time my kids went to the doctor's visit where my husband was taking them. And 10 p.m. the night before, he goes, okay, so what are the questions I'm supposed to be asking? And I was like, okay, well, this is both of us could come up with this list of questions. Was my first thought. But my second thought was, think about how we approach what we're doing, right? How we go about our daily lives, right? So and how do we get them into the hands at the most appropriate time, right? So knowing that parents come when they're coming up for their well child visits, knowing when they turn 9, 10, 11, 12, when they are making the things I think about when my children were infants, right? And what did I need to know at 3 months? What did I need to know at 6 months? And the things now, I'm jealous of the apps now that basically push out basic information that's timed to the relevancy, right? Thinking through, but then also tying it with a trusted source so that you're handed information in part so that you go to places that have developed and tested and validated those information, and potentially, this might be heretical, they're not tempted to then go out into the wide world of the internet and look at a bunch of other things that are not tested and vetted, et cetera, because our health literacy, our internet literacy is not super high, and in the number of things that people think about when, how should I be looking and regarding this information that I read on the internet, and is it a trusted source or not, and what might I be doing to help make sure that it's a trusted source?
Thank you, Jasmine. Thank you all for your engagement and passion around this. It's fantastic to hear the conversations across different contexts. I'd also like you to join me in thanking our panelists for their presentation today. And we'll welcome back Melissa Gilkey.
Great, thank you all again. So now we'll take a 10-minute break. We'd like to reconvene at 10:55. Thank you.
Just a quick announcement, really quick. When we go to camp, we all want it to be warm, sunny days, but we don't always have the ability to control the weather. We know that it's been chilly in the rooms. We've been told we need to keep it cool because of all the AV equipment and the live streaming. So during the break, if you need to, go back to your rooms, grab a jacket, and we will have hot coffee service throughout the whole day. So we apologize if you're uncomfortable.
Well, I know that everyone's still filtering back in from our break. To stay on our timeline, let's go ahead and come together. I'd like to introduce the moderator for our second panel on improving clinical systems. Many of you have the good fortune to know Dr. Marcy Fisher-Bourne personally and the amazing work that she and her team at ACS have been able to accomplish through their HPV Vax program. Marcy, we're so pleased to welcome your panel. The stage is yours.
All right. Hi, everyone. I'm hoping that tea happened or coffee happened so you can stay warm for this next hour. I'm Marcy Fisher-Bourne. Our team at ACS works with inside of ACS, we have around 400 cancer control staff who work on cancer prevention every day. Some of the leaders of those efforts around the field are here in the room with us. I'm really glad to have them here. Some are on phone listening or listening via webcast to us today. So I'm glad, if y'all are listening in, that y'all are here too, along with others. Everyone in this room and everyone listening in today is here because we want to know what works. How can we make an impact? How should we do it? So I know there's a lot of information we just got in the last hour, but just a little bit of connecting the dots here. So we heard about communication messaging that works. We heard about what it means to test some of those and understand hesitancy. And in particular, I would just like to call attention with Greg and with Jasmine. We heard a little bit about some of the challenges that happen in the real world and real health systems in implementing some of those interventions. So with this panel, we're going to talk a little bit about, go back, I'm missing a slide there. We're going to talk a little bit about the ingredients that go into thinking about a whole system and what clinical level interventions can look like, in particular quality improvement efforts. And we're going to start with Dr. Rebecca Perkins. So one of the things that came up, and I believe it was raised just in the question and answer, is around time. When we talk about research, when we talk about a lot of these interventions, we don't have the luxury of time and testing over time. It's great that we have Rebecca because some of her work has been tested over time, and then we continue to be able to implement it in other settings. Then we're going to hear about very large systems, Sanford Health, and just want to call your attention because some things have changed on your tables. I know I see snacks, which is great. The other thing you're going to see on your table are some case studies of systems at work. One Sanford Health, and we have Andrea here. And then finally, we're going to hear from Dr. Jason Turk. He had a great question earlier about the faces of physicians in this story. We're going to hear about his clinical intervention effort and including some videos, which we're going to get to see. So let's talk about what we know works in the clinical setting. When we think about patients, we know that there are a number of things that we can do that are going to help them know that they need the vaccine. So text, emails, phone call, mail. Reminder to you also in your packet are the evidence summary. So what do we know about patient reminders? We know that there's a small to medium impact. We know that sometimes these can be quite costly depending on the mechanism. So mailers, expensive, timely, calls, very expensive, potentially cumbersome, but they're a really important part of the story, particularly when we're talking about completion. All right, providers. So how do we remind the provider? One of the questions that we were talking about with Greg's study with the two iPads, the iPad and the Android device was, did the provider see that iPad in the clinical visit? Did that help her or him know that that was one of those patients that was thinking about the vaccine that day that was ready? So having electronic health records system, having a population health management system, having something that's going to remind that provider, hey, it's time. It may not be an EHR. It may be a person, maybe a team that's going to remind that provider or that healthcare team that it's time. So a morning huddle. All examples of ways that we remind the provider it's time, this patient you're seeing today needs the vaccine. What do we know about provider reminders? We know that in terms of impact, it's also small to medium, really important. In terms of consideration, making sure that there's some language around that recommendation for the provider that can really help increase success. Third thing we know is about assessment and feedback. What's going to be the magic that's going to help us get those high rates we all want to know? So the bottom line is anything we measured, measuring helps us improve things. We know that. So knowing data is going to improve process. Knowing data is complicated, right? Many of us who do clinical interventions know that that's easier said than done, and it's a really potential cumbersome process to help coach, shepherd, understand data in a system. Impact with looking at data, small but higher when we look at those younger populations. Most of all, what we know is what works is combining multiple approaches. So most helpful when we put all those pieces together, when we're thinking about the patient, when we're reminding the provider, when we're looking at the data consistently over time to help that system improve. All of the pieces all together. Other things which sort of seem intuitive, but I think are worthy of saying, is that we know that clinical champions matter. The folks that you're going to hear from this panel are clinical champions. But we know, we know that we need to engage them in their system, right? Some of us in our associations, American Cancer Society is one, we partner, we're outside of the system, right? But we try to do some of our work inside the system, and we know that when we engage those clinical champions inside the system, that we're really going to make an impact. The other thing we know is that providers work in systems. And so we can come up with a beautiful crafted intervention, and we can not think through what it means when there's an Android device and an iPad device, right? And how do we bridge that? So how do we really also understand the systems? Having champions here that are inside the systems really help with that process. Okay, so these are some big questions to hold, and we're going to go through the same process that we were sort of ushered through earlier. But for you to think about, where are we in the clinical intervention space? What are the big questions on the horizon now? And if you hear these questions and you think those aren't them, they're better questions, these are them, talk to your table group, come up and tell us at the end of the time, there'll be time for that. So how can we take what we learned from clinic level success, and you're going to hear some of that today, how do we take it and how do we scale it, right? So I'll use Jasmine as an example. She talked about Parkland. That is a huge system, right? There's tremendous opportunity. So how do we scale? Multiple level interventions. What about the rural setting? Right? Some of our hospital systems do include rural settings, but we know that there are challenges, particularly in uptake in rural areas. How do we keep that, and how do we be mindful? What does that look like when we're talking about providers, patients, data? How do we really think about that in a rural community? And then finally, what are existing mechanisms that might help with scale? So this is completely selfish, but we know through CDC, we have IQIP. We have a group of staff that are trained around quality improvement nationally. How do we use them? ACS, we have 400 cancer control staff, many of whom are trained in leading and coaching around clinical interventions. How might we partner with a group that can help us get our wonderful, beautiful, high impact, great p-value intervention out into the world? So other things to think about is, are there partnerships here in the room? Are there partnerships in our community that can help us really scale these successes? All right, so with that, I am going to turn it over to Dr. Rebecca Perkins, who comes to us from Boston University. Rebecca is an OBGYN. She's on the Roundtable Steering Committee. She's been working with ACS for multiple years. From the moment the Roundtable was conceived, she's been involved and is an incredible champion on the clinic level, helping us think through quality improvement system change, and in general, being that super rock star wanting to make HPV vaccine rates go up in this country. So, yay, Rebecca, come on down.
Marcy. Thanks, Marcy. So today I'd like to talk about some work that we're doing in Boston with a multi-level intervention we developed called DOSE HPV, which stands for Development of Systems and Education to Improve HPV Vaccination Rates. So we saw the problem of suboptimal HPV vaccination rates as well as high HPV cancer rates because we're working in a safety net system with a lot of low-income and minority patients, and we know that's where cervical cancer certainly has the highest burden. And we developed an intervention which has 4 main components. One is repeated contacts. We are persistent like HPV. We just keep coming back and coming back and coming back until they finally listen. Education, I think it's really important for providers to care about why they're doing something. So if you just do assessment and feedback without motivation, people don't really care about making that number go up. So really helping the providers understand about HPV cancers and why the vaccine is important. We did provide feedback because people often think they're doing a great job because they're doing a great job when people come into the office for a well visit, but don't realize that that is not the majority of their population, and there are a lot of people being missed. And then we also offered strong quality improvement incentives, specifically maintenance of certification, Part 4 certification for pediatricians and family medicine providers, which is an extremely cumbersome part of the board certification maintenance process that everybody has to do every couple of years in order to remain board certified. So first we started with a pilot, and this was just in 2 sites. And so we had 2 sites that we were working in and then 6 comparable federally qualified health centers. And we looked at their pre-intervention rates and their post-intervention rates. And then we did what was at that point a 5-session intervention. The first session, we introduced them to the program. We gave them individual data. The second session we call HPV 101, where we give all the information about HPV cancers and vaccine efficacy and safety. The third and fourth sessions were on motivational interviewing. So again, you know, as we heard in the communication panel, the first thing that all the providers need to say is, your child is due for the HPV vaccine today. And for 70% of parents, they don't actually have to say anything else. They're done at that point. But there's about a third of parents who will say, wait, I have a question, and then the providers have to know what to do. And so that's where the motivational interviewing piece comes in. And now the providers are all excited, and they're armed with knowledge, and they're armed with communication tools, but they may be all excited and then actually forget to do anything. So this next session is an action plan, and that's really where we use quality improvement tools and get each individual practice to make a change that supports what they do. So for some people, that's an EMR prompt. For other people, it's having the nurses scrub the charts. For other people, it's changing the template for the 9, 10, and 11-year-old visits to have HPV vaccine pre-checked. So they have to uncheck it if they wanted the child to not get it, but otherwise it would happen automatically. So whatever was going to work in their particular setting. And then the last few sessions were coming back again just to see how things were working. Maybe they tried something, it didn't work out. What else can they do now? And then we looked at post-intervention data. And so the providers received a total of 25 CME credits, which incentivized their continued participation in the entire program. Although what we found was offering these credits was a really nice way to get in the door. Practices, they have to give up time in their staff meetings to hold these sessions, which is a big ask, and saying, we're going to get your entire practice MOC Part 4 was a way to get in the door. People really like that. But then once we were there, because we brought donuts, they said, please keep coming back. They really liked it. And in some of the work we've done around using the same structure with ACS, again, it was a way to get in the door, but actually relatively few providers took us up on the MOC, but they were happy to do the project once it got started because they liked it. So for our pilot study, we compared vaccination rates in our control practices and in our intervention practices to see if there was a difference. And we looked at about 9,000 patients. And so I will say this was happening right around the time when male vaccination was, the recommendation went in as a routine recommendation. So we saw an amazing improvement in vaccination rates for boys in all settings, in the control clinics and in the intervention clinics, but the intervention clinics went faster and to a higher level. We also saw improvement in girls, both in initiating HPV vaccine and in receiving the next needed dose, which is, so if they have 0 doses, they get dose 1. If they had 1 dose, they got dose 2. And at this time, if they had 2 doses, they got dose 3. And so we saw improvements in our intervention clinics compared to our control clinics, both during the intervention period and then also in the post-intervention period, those gains were sustained. So then we decided, all right, we've been able to do this in 2 practices. Let's see if we can step it up, and let's actually do it in a randomized design. So we took 5 of the practices affiliated with our safety net hospital, and we implemented a step wedge design between 2016 and 2018. And what that means is every clinic got the intervention, so they weren't randomized to not get the intervention, they were randomized as to when they got the intervention. And so each clinic served as its own control because we have pre and post data on each clinic, but we also controlled for what are called secular trends, which means what's happening with vaccination overall in the greater Boston metropolitan area, because you would have one clinic that was still in the control phase while somebody else was getting the intervention. And so we were able to see whether the intervention was the same in 2018 as it was in 2016. And so we compare vaccination rates in the pre-intervention period, the intervention period, and the post-intervention period in all of our clinics using very fancy statistical methods that were clustered by patient, nested within provider, nested within clinic to control for all possible competitors. Greg is nodding, so that means we did right. Good. Okay. So our primary outcome was the likelihood that an eligible child who walked through the door of the clinic would walk out with a Band-Aid after having received the HPV vaccine. And that was our primary outcome, but what we really care about is our population. Overall, if we implement this intervention and march forward through time, are we increasing HPV vaccination rates on a population level? So we looked at the cumulative effect on the population level of kids starting the vaccine series and also completing the vaccine series, which was 2 doses if they started before 15 and 3 if they started after. And so what we found was that compared to the baseline period, which you can see here is the pre, happily denoted as the shorter bars, the likelihood of vaccination at an eligible visit increased by about 10% from the pre-intervention period to the intervention period, and the increase was sustained even long after we left. So our minimum follow-up period was 6 months, but we followed up to 2.5 years. And these increases were sustained, which was very exciting because this is a very intensive intervention. And if it only worked while we were bringing them donuts every month, that's not necessarily sustainable. And what we were even more excited to see was the increase in the population level vaccination rates over time. So the blue bars on the left are the entire population of 9 to 18-year-olds, and then the green bars on the right are the 9 to 12-year-olds, so are really our target age. And we see that as we march forward through time, our vaccination rates go up. And the proportion of kids starting the vaccine series, by the time we're done, exceeds the 80% start rate of the Healthy People 2020 goals. And even for the 9 to 12-year-olds, we have reached 80%. So it's very exciting for initiation. Completion is always not quite so exciting, but we do start to see changes even in completion. So we were looking in, I wasn't able to get the super updated graphs, unfortunately, for this presentation. This looks at completion rates in 11 to 15-year-olds in the blue bars on the left, and uses the HEDIS measure definition of getting both shots complete before the 13th birthday, which is the hardest measure to move on the right. And what we see is, over time, we actually see increases in completion rates from about a little less than 50% to over 60% in our 11 to 15-year-olds, and an increase in the percent complete by the age of 13 as well. And I want to say it took us almost 2 years after we started to see a bump in these numbers, because when kids, you always have a proportion of kids who are going to come back when you tell them to come back, between 50 and 60%. And so basically, no matter what you do, you don't need an intervention for these people, they are coming back. So your intervention is going to catch these slow people. And you have to wait for them to show up in the clinic again for some other reason. And you're waiting, and you're waiting. And so if you have a 6-month follow-up period, they will never show up. You have to wait and wait and wait, usually up to 2 years to get them to come back. So we're very excited about these results, and we're collaborating with with Marcy and the VAX program to see if we can streamline this intervention a little bit more, maybe get it down to 4 sessions. And we've been working in FQHC networks, and we're going to try to take on the large integrated delivery systems. And I would like to thank way too many people to list on a slide, my Boston-based research team, the American Cancer Society and their wonderful team, as well as all the participating federally qualified health centers and staff.
Okay, thanks, Rebecca. Next, we're going to hear from Andrea Polkinghorn, who is the Immunization Strategy Leader, which I think is so great that you have this position, is the Immunization Strategy Leader for Sanford Health. Sanford Health spans 26 states and has 40,000 11 to 17-year-olds. So in terms of impact, there's a lot to hear. Andrea is a nurse by background and has really spearheaded and led their efforts. So excited to invite Andrea up to hear more about the work at Sanford Health.
So hello, everybody. Thank you for allowing us the opportunity to present this work to you all today. As she said, I'm Andrea Polkinghorn. I work at Sanford Health, not Stanford. I get that a lot. So I wanted to start out and talk a little bit about our organization, so who we are. The dark blue areas on this graph here represent our footprint. You will notice that it's pretty vast, and we do have some world clinics. But the portion that I'll be talking about in a moment here is really our health services division, which really covers South Dakota, North Dakota, Minnesota, and Iowa. To give you an idea for size, if you are from a healthcare organization as well, we have 44 medical centers. We have 482 clinics. That's a combination of specialty and primary care. We have almost 2,500 providers and over 8,000 registered nurses. So on the graph here, you'll see this is our health services division, those colored areas on the slide, and that's the main area that I typically work with. Internally, we define these areas as regions, and so there's 4 main regions, which is Bemidji, Bismarck, Fargo, and Sioux Falls. I wanted to provide you guys the additional details around those geographic areas if you had more interest, such as patient population, unemployment rates, and stuff like that. So I know the slides have been made available, but I'm not going to go through that during the presentation today. So why should a healthcare organization prioritize an HPV improvement project? And I guess my question is really, why not? So we all know in this room that immunization rates are low, but I would say internally at Sanford, when we started our work, there was not only a lack of knowledge about how we were doing internally, but also nationally. And so we wanted to obviously work on this for those few of us that did have awareness. We also know that healthcare systems place high priority on preventative medicine, which is exactly what vaccines were. But at that time, we weren't doing anything to evaluate how we were doing or how we could do improvements. So we did end up pulling our internal data and compared that against the Healthy People 2020 goal of 80%, and that demonstrated that we had a significant amount of work that needed to be done to better protect our patients. So then what we did once we pulled that data was really developed a course of action that we thought would work to improve HPV vaccination rates. And thankfully, we were able to secure some funding through North Dakota and South Dakota's comprehensive cancer coalitions to help support that work. When we took that to our executive leadership, you know, we had low rates, a plan of action, and funding to support that work. It was essentially a no-brainer for them to buy in and help support us moving forward. So as everybody's talked about, data is crucial. At the time of this work, when we began in 2015, I did put up on the slide here how we pulled our data. So for HPV at that time, we did pull males and females, all of them 11 to 26 across the board. And part of that is because we had heard from staff there was some confusion about, you know, males ending at age 21, and we just wanted to simplify it, knowing that it wasn't going to cause any harm and should be covered by insurance. Additionally, we didn't decide to, you know, push back and evaluate 13 to 15-year-olds. We really wanted to know 11 through 26, all of those eligible people, how many of them had not started and who had completed the series. And then I'll get into it more, but for HPV, we did want to monitor those who had no doses and those who had completed the series. Just like Dr. Perkins talked about, it takes a little bit of time to move that series completion number. In addition to that, HPV was our first data pull for immunizations, but we also want to pull Tdap and MCV4 because we know these vaccines are administered at the same time as HPV. So for Tdap, we pulled males and females 11 to 18 years, those who had had a dose. And then for MCV4, we pulled 11 to 15-year-olds who had had a dose, and 16 to 18-year-olds who had had a dose on or after their 16th birthday. So on this slide is an example of the data that we would share with our clinics on a monthly basis. In the beginning, we did graph this level down to provider level data for each clinic. As you'll hear me say, we started with 7 family medicine clinics, so that was manageable and doable at the time. But as we continue to expand that work to more and more clinics, it simply became unmanageable. So we transitioned just to clinic level data being graphed, but always sent the PDF to the clinic so they could continue to track provider level data if they had that desire. We knew that we wanted to track patients who had never received a dose of the HPV vaccine because it's more enticing to staff to see, hey, you know, I'm trying to catch these patients up, I'm recalling patients, getting them in the door, and so we can see that number drop very quickly when you compare it to series completion, which takes 6 months at best to see that rise. In addition to that, we did a ton of education on how to recommend sandwiching the HPV vaccine, not missing opportunities to vaccinate, So that is why we wanted to track MCV4 and Tdap rates to see if our education around those initiatives, offering all the same way, the same day, would be effective at improving those rates as well. And as you can see from the data, it was successful. So on the left is the baseline data, and then all the way on the right for the bars is September of 2017 at the end when we concluded our second year grant. And then the Healthy People 2020 bar is in red. So interventions that we used, one of the first ones, as I alluded to, was to meet with our clinic leadership. We really needed their support to encourage staff to attend our education. We've all talked how it can be challenging to get providers' attention in particular. So we did have them essentially mandate that staff come whenever we came for education. We also needed them to support an expectation that clinics were going to be participating in this project and that we needed to do a better job. The second was staff education. I can't say enough about the education because at the time, the knowledge base that our staff had, they really didn't know a ton and how to confidently recommend and talk about or address questions that came from parents. So important, that step. We did do inpatient in the beginning, and that's really ideal. They are more attentive when you're right in front of them, and they're more inclined to ask questions. When we hold the webinars, which we do now more often just because of our reach, they're not as inclined to ask questions. So if you have the opportunity for in-person, I always promote that. The third thing was distribution of those immunization rates on a monthly basis. And so the hope is through them doing these initiatives, they would see improvement in their rates and would be encouraged to continue doing the work that they've been doing. Step 4, we did hold monthly meetings with leadership from the participating clinics, and that was really an opportunity for them to get together, to share wins, to share barriers, and their current progress. We did institute reminder recalls, so we did a combination of reminder letters, automated phone calls, and in the second year of the grant, we did pay for some nursing time to make personal phone calls to patients, and I'll get into that in just a minute here. We did a marketing campaign, which we had historically not done, just on adolescent vaccines in general, so that was something new that we had done as part of this work. And this stuff is kind of phased out, but at the time when we initiated this project, Merck did have some nice reminder magnets that would flag when the patient was due for the next dose. Our staff really loved the magnets, and we're sad when they went away. But we transitioned to, Merck transitioned to a text reminder program. We did use that, but that has since phased out too, but just some type of process to get patients to know that they need to come back for that second dose. Next, we did do screenings of the Someone You Love, the HPV epidemic documentary at some of our local colleges, which was great as well. So now I'm going to share some of the results from the work that we did on the South Dakota grant. As a reminder, we secured the grant in South Dakota for 2 years. So that first year, we picked 7 family medicine clinics in the Metro Sioux Falls area. And in year 2, because of the success that we had, the Cancer Coalition asked us to expand that work to our additional South Dakota sites. So as previously mentioned, we sent both reminder letters and automated calls to patients who were due. In year 1, the 7 family medicine clinics, we distributed over 20,000 phone calls and letters. And again, that was just for those 7 sites. In year 2, we did automated phone calls. Those were only used for the new 32 clinics because in year 1 with those 7, we did a combination of 2 rounds of automated phone calls and 2 rounds of letters. And so our thought was, with all of those contact attempts, if they hadn't been successful, that they probably weren't going to be in the future. For the initial 7 family medicine clinics in that second year, we did really focus on series completion of those that we had been able to get started, and we paid for nursing time to make personal phone calls to patients who were overdue. When we evaluated the data from the personal phone calls, they were very effective for the 11 to 17-year-old patient population, but not as effective for those older adolescents or young adults. And then lastly, again, we had mailed letters to patients who were overdue. This graph shows the total number of HPV doses that were administered pre and post intervention. On the left is year 1 with the 7 sites. We had our doses increased by 1,432 in year 1, and in year 2 we increased by 3,351 doses. This graph here just displays the overall decrease in 0 doses for both year 1 and 2. The dark blue line represents year 1 for the 7 family medicine clinics, and the year 2 is in the gray bar, which represents all 39 sites combined. This one is essentially the same thing, it's just for HPV series completion. So dark blue is the 7 sites, and the light blue is all 39 sites combined. So lastly, the grant concluded in 2017, but I wanted to provide you guys a demonstration of where we're at today. So this is that initial pilot group of the 7 family medicine clinics. On the left side, that dark blue line is their baseline from 2015. And the the royal blue line is from June of 2019. So this work has been great and being sustained. I do want to lift up, when we started this work and evaluated data, most of our family medicine and women's health clinics had about a 70%, their rate was 70% of their patients who had never received a dose, so really come a long way. And then this is those clinics' series completion rate as of today. So the bright blue line is their series completion rate today, and at the 80% line there, you'll see the gray bar representing the Healthy People 2020 goal. So our achievements, as I said, the state had asked us to apply for that grant for a second year because they thought it was very successful, as did we. We have had numerous clinic and staff receive awards from either the Department of Health or the HPV Champion Award. We did create a VaxChamp program, which is a 6-month education and training program for RNs, LPNs, or CMAs, which has been very successful. We've gotten some national recognition for our work, which has been great. We've really enhanced the knowledge and awareness of staff around vaccine hesitancy and where immunization rates were at. We have, I am now sitting on the IDS HPV group, which is great. We've been able to participate in other projects such as AMGA's Learning Collaborative. We've seen an improvement in vaccination rates for other vaccines that maybe we haven't even necessarily put a specific focus on. It's just part of that culture change that we've been undergoing. And we've built multidisciplinary groups to help guide and standardize all of our immunization practices at Sanford, such as our Enterprise Immunization Committee. So lastly, key lessons that I would say from our experience. It's really nice to have some type of dedicated personnel who has a large system approach so that you can make broad impact opposed to just into one clinic within a healthcare system. Obviously, something is better than nothing, but that is best. You have to pull your data, and I promote data transparency. Those doctors don't like to see their rates up against their peers if they're underperforming. They like a little bit of competition. So you really need support and buy-in from your executive leadership and key stakeholders. Education, I'm not going to go through it all, but that's typically some of the stuff that we covered in our education. Create a vaccine champion to help support and expand your work. Secure funding, there's tons of funds out there, you just have to apply for the grants. Share your wins, that's huge. I'm always sharing all of, even that I'm here with you guys today, as a win. And have conversations with underperforming clinics and providers. Oh, and Jen's giving me a note that there's a case study on your table. I'm out of time. Thanks.
Thanks, Andrea. Next, we're going to hear from Dr. Jason Turk, who is a pediatrician at Cook Children's Physician Network. In addition to being a fierce vaccine advocate there and with his patients, Dr. Cook is also chair of the Texas Medical Association Council on Legislation. He also advocates for vaccines through TMA's Foundation B-Wise immunization program. He's past president of Texas's Pediatric Society, and currently he serves on the American Academy of Pediatrics Committee on Federal Government Affairs and more. Please join me in welcoming Dr. Jason Turk.
Good morning. Yeah, I'm Jason Turk, and I'm a vaccinator. Right? So really appreciate the opportunity to come speak with you all today. And as was mentioned before, I'm with the Cook Children's Healthcare System Physician Network as the group practice. I have no conflicts to disclose whatsoever. A little bit of background. We all understand that primary care is more and more moving toward integrated healthcare systems, and that's a change that's been going on for quite a long time, but is accelerating. And a decade ago, almost half of us worked in small private practices, but now only 15% of us do. The majority of us entering practice join larger healthcare systems in which there are opportunities for interventions like this. This is terribly important with respect to how we approach quality improvement with HPV. We have usually existing quality improvement infrastructure within healthcare systems and academic centers. We have the ability to look at vaccination data across the entire enterprise of a healthcare system or an academic institution. We do have significant challenges, though. We are dealing with heterogeneous populations. In my own institution, the type of patients that I see are qualitatively different than the types of patients that some of my colleagues see in other parts of the region that we practice in. Implementation of interventions can be a challenge across a geographically large area, as I'm sure was experienced by the Sanford group. It's a challenge to get to everybody and to make sure that everybody's on the same page and aligned correctly. And then there's only a certain amount of bandwidth within organizations, and you oftentimes have to compete with other priorities, not just quality improvement priorities, but other system priorities. And culture is a huge part of how successful an organization may be in these kind of interventions. So, virtual rogues gallery of people that you might recognize here that I was fortunate to participate with in our particular project. We all know Dr. Gilkey and some of the collaborators we had with Marjorie Margolis and Emily Newman. We already have met Annie Laurie. Many of these folks were involved in helping me execute our quality improvement initiative at my organization, and we're part and parcel of the work that we did and that we eventually got published, actually, a couple of months ago. So a little bit about my organization. The Cook Children's Healthcare System is probably one of the largest integrated pediatric healthcare systems in the United States. The system includes a hospital, a physician network, which is the pediatric group practice, a foundation, a home health company, soup to nuts. We pretty much have it covered in the greater Fort Worth, Texas area. We have over now 90 to 100 pediatricians now, that serve pediatric patients in our area. This is the data that existed at the time that we started our project. Overall, we have almost 600 pediatrician and pediatric subspecialists within the Cook Children's Healthcare System. And primary care practices are arrayed across the greater Fort Worth, Texas, Tarrant County, and 5 counties surrounding the area. And we all share the same electronic medical record, which at the time was Athena. I'm not a shareholder, I can say that. We're now on Epic, like many other folks are. So this is where we were at the beginning of our journey. One of the unique things that we had at Cook Children's was the ability to drill down and get provider, physician level performance data for the percentage of their 12 to 14-year-olds who had one or more doses of an HPV vaccination. And you can see the tremendous spread of performance across our enterprise. Average was not unlike what the national and state averages were at the time for that particular cohort of patients. But we had some extremely high-performing folks, and we had some extremely low-performing folks, and more people kind of clustered around the middle. And this is kind of where we were when we started. And again, the actual data point that we were looking at is one or more doses of an HPV vaccination for 12 to 14-year-olds. We selected that because we wanted to capture the population that we thought absolutely should have at least one dose. And in my state, it's required that people get a Tdap and a meningococcal vaccination before they enter 7th grade, and we had comparator data, as people have already discussed, with rates for Tdap and meningococcal vaccination. So the aims of our study were to conduct a 6-month QI project using our existing resources, but which were adapted for our particular organization. We wanted to look at how well we could reach all of our pediatricians and in their practices. And we wanted to evaluate the impact of our intervention on this particular cohort of patients in our organization. Study design. So at the time, we had a total of 33 pediatric clinics. We're talking about the spring of 2017. There were 8 clinics that were excluded. One was my office because our office served as a pilot for the project and did not participate in the actual QI intervention as a result. There were 7 other clinics that lacked provider-specific patient panels. All the rest of us were able to get a specific denominator and understood this particular patient belongs to this particular physician. These other 7 practices did not have that, and so we could not get a good denominator. And so we then were left with 25 clinics that were randomized. 13 were in the intervention group that included 45 physicians, and then there were 12 that were in the waitlist control. Those folks were engaged after the 6-month period and got the same intervention for the benefit of their patients and practices. So what were the interventions? Well, myself and 4 other high-performing pediatricians on that part of the curve that we showed you before engaged these offices. I trained them to let them know what we wanted to do, and then we sort of fanned out to our organization. We scheduled 1-hour interventions over the lunch hour. The intention was for all of the physicians, all the clinical staff, all of the upfront administrative staff to be involved in those meetings, because communication across the entire experience of a family is terribly important. They need to get the same message. The high-performing pediatrician peers gave a PowerPoint presentation that included information about the vaccination, why we give it, why the current recommendations are there. And we also had some video vignettes that we showed, which we'll have a little sampling of in just a moment. We offered CME credit. After the fact, we were able to secure maintenance of certification, Part 4 points, and I became everybody's best friend at that point. So this is an example of one of the vignettes that we used. And I think it's important for us, probably for other folks, for them to see something that resonates with where you're practicing. The physician here is one of my practice partners. The mom is one of my other practice partners, and the child is her daughter. So seeing your partners doing this resonates more than some sort of nameless person you've ever seen. Go ahead, please.
Well, that foot's going to be sore for a few days, but it should start feeling better by the end of the week. Let us know if it doesn't, okay? Okay. Oh, I see that you just turned 12. Well, now's a good time to talk about those vaccines that are recommended at this age, the HPV, the Tdap, and the meningococcal. Do you have any questions on those?
Mom, that's 3 shots.
Yeah, the HPV vaccine, I mean, don't you think we can wait till she's a little bit older for that?
I think I catch your drift, and I know it seems really soon, but the sooner we protect her, the better. Isabella's response to the vaccine is actually better as a young teen, and her immunity will build up over time, and that immunity will be available for her later on when she needs it. That's true for many vaccines, not just HPV.
Yeah, we've talked about this before, but I mean, it's years and years before she needs protection like this. I would feel better if we waited.
I understand your concern and that you just want to make the best decision for Isabella. We all do as parents, but protecting her now against an infection that she's likely to get and can cause cancer is definitely the best decision. It's a decision that I made for my own children, and her response to the vaccine would actually be better now than as an older child or an adult. And if she gets the vaccine today, she will only need 2 doses instead of 3.
Yeah, well, I just am wondering what we might be opening the door to.
Well, I think that's a reasonable concern, and it's a question that many parents have asked. It turns out there's lots of studies that show that there's no increase in sexual activity or any earlier sexual debut. I hope that that brings you some reassurance.
Well, I just don't know.
I think it's pretty amazing that we have a safe and effective way to prevent cancer. I mean, 20 years ago, we dreamed of having a vaccine that could prevent cancer, and this is it. I would feel a lot better if we got her protected today.
Okay.
So, thank you. I want to give credit where credit's due. This is based upon the Minnesota Department of Health video vignettes. We adapted them, but kudos to them for giving us the basis for what we did. But yeah, it really resonated quite well. And there were 2 other vignettes that we used, one of which was a really vaccine hesitant person that took a lot longer to convince, but was representative of what we see. So in each one of these interventions, each physician got their own specific assessment with their data. Here is your rate for this patient population compared to your partners in this particular practice, as well as the clinics. And so it was their information, and we were completely transparent about it. We said that here's everybody's, it's all out there, and that's what we did. And nobody really pushed back against that, because we all are trying to do the best we can. And that's a really important thing when you're doing these interventions. If you walk in and say, look, you guys are pretty lame about what you're doing, and we need to help you with this, no, that's not going to work. If you reach out to them and you say, you know, this is hard. We know it's hard. Everybody's having a struggle with it. We found some things that have helped us. Let's share this with you so you can do better too. So they got an immunization report card at baseline, and then they also got one at the midpoint at 3 months beyond the intervention, and then they got a final report card at 6 months. At the baseline point, they had a specific numerical goal that we gave them to try to get better with on that particular patient population. So it wasn't just get better, but get better by this amount. And this is what that physician report card looked like. So again, adapted from materials that Dr. Gilkey had used in some of her prior work. So the analysis, we looked at reach, the percentage of practices and pediatricians who participated, and we looked at the impact on HPV vaccination rates in that cohort for each one of those physicians. We used hierarchical linear modeling with a full sample intent to treat, and we had a sensitivity analysis which excluded MDs with poor data. What does that mean? I'll get to that in a minute. Reach, we got to all of the 13 practices that were in the intervention group. We got to 95% of the pediatricians who were in those practices. Where were those other 2 pediatricians? Well, I'm a minority in my specialty, and it was very inconvenient that 2 of our pediatricians decided to be pregnant in the middle of our study, and they were on maternity leave. So anyway, it happens. I'm the only Y chromosome in my office. All right, so here's the results. So the full sample, this is the percentage point increase in the quality improvement arm versus the control arm in the full sample on the left graph. And there was increase there, but not statistically significant. When we excluded physicians with poor data quality, we did reach statistical significance in the difference in percentage point increases between the control and the intervention group. Who was excluded? Well, as happens in large healthcare systems, people move around, clinics close. And after randomization, there were some physicians who shifted from an intervention clinic to a control clinic, or clinics that closed and we weren't able to use that data. And so there were a number of physicians, a small number of those physicians, who had to be excluded as a result. And after we excluded those folks, we did reach that result that was significant. So we got fantastic reach. We increased HPV vaccine provision, but the increases were small. We saw them for both the control and the intervention group. We're happy about that. The Train the Champion strategy worked well for us. It's worked in other environments and contexts before. And the opportunities for further study are how can we increase the impact of these interventions? What are the mechanisms by which we change behaviors? And then how do we assess implementation outcomes? Just to tag along with what's been previously talked about, and I think it was really important to make clear that when we are in an intervention with a particular family, we've gotten past the announcement, we're now addressing vaccine hesitancy. If somebody says, I'm worried about this, or I'm scared, or I've heard this on Facebook, we might think it's kind of ridiculous, but they're sharing a moment of vulnerability. And just like they might express something else that they're vulnerable about, we have to engage them in a respectful way in that vulnerable moment. And when we do that, we can be successful talking about what their specific concerns are respectfully. That's the end of my presentation. Thank you.
Thank y'all all very much. We're going to have a slight pivot in terms of table conversations for this second component. And so the challenge is going to be, after you get lunch, to come back and have some very juicy conversations during your lunch hour. There are prompts on the table to help you. But to keep us on track, we're going to actually move to our Q&A portion. And I've been getting some information from those that are live streaming. We have folks that are web streaming in Iowa, North Dakota, Massachusetts, South Carolina, Mississippi, and Maryland. And we're going to start with one question that's coming from them. And the question is for you, Andrea, for Sanford Health. So you started with a very big net in terms of age group from 11 to 26. Mm-hmm. Are you still there? Are you looking at younger age groups, 11 and 12? Where are y'all now in terms of population?
Yeah, so that report is fairly complicated. Once we got the 2 and 3 dose, we had kind of left it alone, but recently with the new ACIP, recommendation and FDA approval, we're still going to keep the same age range, but we're going to narrow it into pockets of groups so that we can have a better analysis of how we're doing by 13 and the older population. So we're altering it just a little bit.
Great. Okay. We're going to open it up to questions from the audience here. Anyone have questions for our panelists? Sarah.
Hi, everyone. Sarah Cobrin, National Cancer Institute. Andrea, my question is also for you.
Yeah.
You mentioned that you were getting recognition, local, state, even national recognition for the people who are working on your program.
Yeah.
So congratulations first.
Thank you.
But second, I'm thinking about that as another intervention element. So how did it influence people's enthusiasm? What do you think was the impact of people being recognized, and might that be something that programs could develop?
Yeah, so a huge part of that actually is our VaxChamp program. So when they go through the VaxChamp program, they have to actually select a vaccine that they want to work on to improve the immunization rate for that. So that's part of that. And it builds a healthy vaccine culture within those organizations. Many of the locations that were selected for an award or the person, either we're a VaxChamp or we're from a VaxChamp clinic. And then the other piece of that is I am always sending out and promoting recognition. So with all the nominations being available for the HPV Champ Award, I'm sending that out to all of the people that I collaborate with and saying, please, nominate your peers, because I know that we're all doing phenomenal work.
Right. Yeah, I think it's a great model. Maybe other places could think about using that kind of recognition to boost their programs. Thank you.
Thank you.
Great. One more question.
Hi, Jane Pazua from California. This question's for you, Dr. Turk. I'm very curious to hear about the training. You said you included all office staff, clinic staff, not just providers, but didn't really see a lot of information in the presentation. So I was curious if you used the exact same training with other office staff, like nurses, MAs, and non-clinical staff, and then also what their participation looked like compared to providers?
So we didn't specifically track non-physician folks that attended the intervention sessions, but everybody was in the room when we gave these presentations over lunch. Clinical staff, administrative staff, non-physician folks, as well as the physicians. They all heard the same presentation at the same time, and they all asked questions together. And doing it together was really important, an important dynamic, because it underscored the part of the intervention, which is that when a family is engaging a practice, they need to hear the same message from everybody.
I agree very much. Thank you.
Great.
Yeah. Hi. Thank you for the presentations. I'm Jane Zucker. I'm from the New York City Department of Health. My question's for Andrea. Yeah. Because of the network, have you looked at whether or not the network is seeing less genital warts or any other impact? Because it seems like to make the business model to, emphasis, why should a large network invest if they can actually start showing that, wow, we actually have lower healthcare costs for some of the earlier outcomes? That would be a great business model, and I think help in that, why they should invest in a program.
Yes, thank you for the question. We have definitely talked about it. I have not got my arms around how to, talk about reduction in costs from disease prevention and stuff like that. I've heard from some people who are maybe a little more in tune to that about potential ways to do that. We just haven't done that yet.
And then I just want to say, from a health department perspective, and I guess this may come up with the table discussions, we have participated in AAP QI programs, and quite frankly, they were really labor intensive for the practices as well as for the health department. And we didn't see enough bang for our buck to continue to make that kind of investment. So, and I know there's a lot of other projects going on, but I'd really at some point like to hear about back to scalability and, what do you do once you take it outside of this kind of research setting where you have the support you need for an intervention? Thank you.
The bang for the buck, we have one more question, Melissa, and this is also from online. If you had to pick, and we'll start with Jason and work down, if you had to pick one of the strategies, one of the evidence-based strategies inside of your practice, your system, what would you say is the most important, most successful?
I think that probably, if I had to pick one part of the intervention, having a video vignette that was crafted for your organization was probably the most important. It was not the only thing that I think was important, but if I had to pick just one, that would be it. And then if I would be permitted to say one plus, would be having...
If I were to change the rules of the question.
Would be having physician or provider specific information that is shared with everybody in a transparent way, in a very sort of big boy pants way, that we're in this together and we can share this information and work together.
Great, thanks.
Mine would actually be staff education, just because I know where we were at and where we're at today. And if I had a second one, it'd be data transparency too.
Well, and in both of your examples, staff education included the entire system.
It did.
And I think that's really important to note.
Yeah, and in ours too, we included, everyone was welcome at all the sessions. So I would say that the data really showed that a single element doesn't work very well. So I don't think you can really do that. And so that's where I'm like, well, education's really important, but you also need data. And I think that's really true. You need the 1-2 punch of the motivation and the reality check that actually shows that you need to improve and then shows the improvement.
I do think, though, a common element is the personalization piece. That can be through the video, that can be through physician-specific data. I think that's a really important element in all of your stories. So, all right. Thank you. Melissa.
Thank you all so much for a great panel. We are now going to break for lunch. Lunch will be held in the same room where we had breakfast. We did not assign seats, so feel free to sit with your cabin mates or meet somebody new. We will have a brief lunchtime presentation by Dr. Bob Benarchik on HPV vaccine effectiveness and safety, and that'll start at 12:40. So feel free to have lunch, keep eating, and enjoy the lunchtime period. We'll meet back here at 1 o'clock to have a conversation with Dr. Saad Omer on school entry requirements as a promising practice to support HPV vaccination. Please enjoy lunch.
Thanks, Jill. Thank you.
Thank you.
If we could come back to order, please. Thank you, thank you. So you'll remember that our next panel is about school entry requirements. We're going to welcome Dr. Saad Omer, who's a professor of medicine at Yale and one of our nation's preeminent vaccine policy experts. Dr. Omer graciously agreed to present today while he is in the midst of relocating. Even when he was stranded last night at LaGuardia Airport, he was still committed to joining us. Unfortunately, he's not able to be here with us in person, but we're going to try to Zoom him in. So please call upon any luck you have with the AV gods, and we'll welcome him now. Thank you.
Hi, everyone. Good. So I have the benefit of speaking right after lunch. Hopefully you had some caffeine with some food as well. And I know Bob Bernarczyk is a really nice speaker. As I recall, he was going to be the lunch speaker. I may be misremembering, but in any case, my hope is that this slot is a good slot to discuss something a little provocative. And what I'll do is I will talk a little bit about evidence surrounding all kinds of vaccine mandates, i.e. related to childhood immunization. Then I will raise a few questions. I will cover a little bit of evidence around HPV vaccination, and then the rest of this block of time will involve a little bit of a discussion with Noel Brewer, and we will use a quasi-Socratic method, I guess, to flesh out some of these issues. So the term which is often used around this phenomenon is mandates, but some of us prefer, and I personally use it interchangeably, the term requirements, because that's less charged and covers the same concept. But I do use the term interchangeably because mandates is often used in the press, etc., in common discussions so that people understand what we are talking about. Mandates or requirements fare reasonably well when you compare them head to head with some of the other interventions to increase immunization coverage based on the available evidence. And this was a really nice review that Noel Brewer and colleagues did. It's a pretty extensive review. So when you're reading it, stay hydrated because it does take some effort to go through, but it's worth your while. And when you look at likely impact, vaccine requirements are right up there with things like healthcare provider recommendations, presumptive healthcare provider recommendations, on-site vaccinations, default appointments, incentives, etc. So there is evidence that immunization requirements overall as a concept can be useful. However, there are a lot of nuances, as you will see. Just to provide an overview, school immunization requirements are based in this country on state laws, and that's because we have a federal system, and constitutionally some of these powers rest with states. So these are based on state laws, not federal. So therefore, there is contrast in terms of the kinds of laws that are there, and that helps us study different variations of these laws. They have played a major role in keeping the rates of overall vaccine preventable diseases low. And obviously HPV is a slightly different case, and I'll come to that. There are three types of exemptions that are allowed: medical, religious, or personal belief, or philosophical exemptions. Vaccine exemptions vary by state. Right now, there are no exemptions, non-medical exemptions. Until recently, in California, Mississippi, and West Virginia, a couple of states have recently, for example, New York has added to this. But in terms of what these are new laws, so therefore there isn't data on impact of these laws. But there are certain states that have only religious exemptions, and other states have both religious and philosophical exemptions for childhood vaccinations. We looked at data, and at that time, California hadn't eliminated its non-medical exemptions, of looking at ease of obtaining medical exemptions by state. So not all mandates are created equal, and therefore how easy it is to obtain an exemption is important. And so there is a little bit of a gradation, and that gradation is an update of a CDC approach that was first introduced in the late 90s. We have been updating it through, based on, for example, the expansion of the use of internet-based tools, etc. And essentially, it ranges from you go to a website, you print out a PDF, check off a box, and you file an exemption for the rest of the stay of that child in the school district. On the other hand, certain states allow for, require that you go through physician counseling or notarize your letter for exemption, etc. So there's a whole range, and you can create a scale. And that's what we did and classified ease of obtaining vaccine exemptions against childhood immunization. So these are laws being implemented at kindergarten into easy, medium, and difficult. And so we had previously shown that not only that the rates of exemptions are associated with this, and I'll come to that in a second, but the ease of obtaining exemption has an implication on the rates of vaccine-preventable diseases such as whooping cough or pertussis. For example, in this 2006 study, we demonstrated after some pretty aggressive modeling and being very conservative about what potential confounders could be, sort of impacting this association, we found that states with easy exemptions had approximately 50% higher incidence of pertussis compared to states with difficult exemptions. When we started looking at it back when on non-medical exemptions against childhood vaccination, we saw a little bit of a trend, but it wasn't very dramatic. But then we classified, and this is the later data, we classified
Are you there? We've lost your sound. I see him on my screen. You're frozen. Can you rejoin? Yeah, it shows he's disappeared.
I would like to take personal responsibility for this because I was sitting there thinking, oh my gosh, this is going so well. I'm pretty sure this is all my fault. Sorry. We're going to give the AV folks a couple more minutes to fix this. Noel, I wondered if you would lead us in the kind of polling exercise that we had
We're back.
for the end. Oh, we're back. Okay. We'll save it. Thank you.
Okay.
Yeah, so, hold on, sorry. Can you see this? Can you see my slide? Can you see my slide?
Yes.
Okay. So sorry about that. And fortunately, I had a second computer ready. So I connected on a different computer. I don't know why my computer crashed. Macs don't tend to crash, but so based on the type of exemption permitted, there was a difference in not only the rates of exemptions, but how fast they were rising at that time. And so this paper came out in 2006. But there was another trend we picked up where we looked at easy, medium, difficult exemption policy, and we found that states that had easy exemption policy had disproportionately high rates of exemptions, but also there was an ongoing increase in those rates. This trend continued, and it turned out that states with religious exemption policies actually started increasing in terms of their exemption rates in subsequent years. But states that had difficult exemption policies remain protected from that trend. And that has continued overall since, although there's some nuance in those data. But why do we look at, when we look at these phenomenon at the state level, it kind of hides what's happening at the local level. So this is a study we did in Michigan, where we looked at local clustering of vaccine refusal, or as measured through immunization, exemptions to immunization requirements, and their overlap with whooping cough or pertussis. And we found that the odds of a census tract being in a pertussis cluster when they were 3 times as high if the census tract was also in an exemption cluster compared to a census tract that was outside an exemption cluster. For HPV, again, this is a different kind of clustering that you worry about.
We're having an issue again.
If you wanted to obtain an exemption, and this law went into effect in July 2011, and what it did was it had a reduction in, so if you looked at a trend line, so there was a variation around that trend line, but there was a reduction in non-medical exemptions, so they gained approximately a decade after this requirement of physician counseling, this requirement of physician counseling to obtain non-medical exemption. But, you know, as I mentioned, there is local variability in these rates is important in terms of actual disease transmission. And so these are data from Washington State, where traditionally there has been a lot of variability in these exemption rates. For example, ranging from 1.2% in Yakima County to approximately 1 in 4 child being exempt in Ferry County, Washington. So we looked at spatial heterogeneity as part of this law, and that's the other point. When you're considering any mandate against any, for any vaccine, local variability, school level variability, census tract level variability, even zip code level variability is important as an indicator, as an outcome to pay attention to. So what this law did was not only that it reversed the trend or stabilized and then subsequently reversed the trend in terms of overall exemption rates, but it also had an impact on local clustering. And so if you read left to right and from top to bottom, you'll see that there was an increase in clustering in Washington State, but then after this law, there was a decline in clustering, but there were a few intractable clusters. For example, in southern Washington, and we are seeing some of these outbreaks in those clusters of measles in recent years or in recent months. California went one step further and eliminated their non-medical exemptions altogether. So, but before that, there were a couple of other things that were happening. So they did, earlier on, they had a law which was similar to Washington that added requirement of physician counseling before you could obtain an exemption. Then they had a crackdown on their conditional entrance. So these were, this was a provision in the California system where you, for example, would say that I intend to get my child up to date on vaccination. They have started a schedule, but I will do it, and they would be allowed to attend conditionally. Not all schools uniformly followed up on these conditional entrants, and so a lot of them remained unvaccinated, although the reason was different than non-medical exemptions. So what happened was there was an education and sort of a little bit of a crackdown, but crackdown is a strong word. So there was an effort to reduce conditional entrance in California. And it turns out that had a pretty substantial impact. And the third thing was this law that, as I mentioned, was to eliminate non-medical exemptions. So now what has happened is that there has been a decrease in those who are non-up-to-date on vaccination, but a lot of that change has come from the conditional entrance program. There has been a decrease and almost elimination of non-medical exemptions or personal belief exemptions. There has been an increase in medical exemptions. People have recognized this offset in medical exemption, but that is not the biggest increase. The biggest increase is in situations where the mandates are not applicable. So the law doesn't apply to them. And so there are certain provisions that don't apply to a few people, for example, certain kinds of homeschooling programs. And then there are certain people who are just overdue. So where, they should be vaccinated, this is a catch-all activity, sort of category, they should be vaccinated or should have proof of exemption or other categories, but it's a little bit of a diagnosis of exclusion. They're not just vaccinated. So there is near total replacement in terms of a replacement compared to non-medical exemptions or personal belief exemptions in California. But the increase in vaccination rate has come from this administrative effort to reduce conditional entrance. So the data are nuanced. And we shouldn't be surprised because previously, in terms of medical exemptions, we had shown that states that had high difficulty in non-medical exemptions had relatively higher rates of medical exemption. So if it were more difficult to obtain a non-medical exemption, there was an association of that phenomenon with relatively high rates of medical exemption. But at the state level or at the national level, if you look at state by state data, there wasn't a total offset. So the magnitude was different, but there was this phenomenon where if you tightened the valve a little bit on one side, the pressure was let out from the other side. In California, one of the interesting things was that there was elimination or substantial reduction of clusters which are clusters of non-vaccine up-to-date or not up-to-date vaccination rates, specifically in Southern California. There remain some clusters in Northern California, but the intensity has decreased. So looking into some of that evidence from here and other data, a few of us came up with a little bit of a framework, and I sort of synthesized it with my colleagues Cornelia Besch and Julie Thies from Germany and Australia, respectively, obviously. And we proposed a framework where we say, look, there are several pragmatic and ethical issues that governments and jurisdictions and health departments should consider when thinking about a mandate, irrespective of the vaccine you're considering. First of all, ensure that everyone can access vaccines. So that includes a stable vaccine supply, making the clinic experience welcoming, etc., and having a robust safety system. The second step is that mandates or requirements should not be standalone interventions. They should always be paired with a robust assessment of why under-vaccination is happening, but also apply other evidence-based interventions. But when you do implement mandates or requirements, ensure that the procedures are fair, the penalties are appropriate, you compensate for real side effects, and avoid implementing selective mandates. So that's one thing for childhood vaccination, which I can come back to. where, when it has been tried in a few European countries to make one vaccine mandatory and other not, people think that the other vaccine is less important. So we should think about that in terms of teen vaccines, and if certain vaccines are mandated, the other ones are not, then there may be some perception that the other ones are optional. So some data from Europe indicate that some parents perceive the non-mandated vaccines as such. So how do you strike that balance? How do you find that sweet spot? So my suggestion is to be a little bit careful about eliminating all non-medical exemptions, but changing the balance of convenience of obtaining exemptions in a manner that it's easier to vaccinate than not to vaccinate. So there are a few requirements that state can have in their laws in terms of signing a form that discusses risks of non-vaccination, in-person counseling with a provider, which I think is very important. And I'm a big fan of this approach, but there are nuances in terms of how to implement that as well. Procedures to review each request for exemption, and we have done work separately to make it financially feasible for health departments, but I'm not going to that. Then there are states that used to do, and then still do, letter elaborating on the reason of their child should be exempt. But now with the internet, there are form letters available from groups that don't particularly like vaccines. And then sort of obtain the form by specifically requesting from state or local health department versus downloading it online and just checking a box, and then annual renewal of these requests. And why to my mind, it does make sense, because you're asking a group of parents to go out and get their child vaccinated, and those who follow the schedule make an effort to take time off of work, pick up their child from school, if depending on their age and time of the year, go to a pediatrician's office or another place where the vaccine is available, and then complete the schedule to protect not just themselves, but others as well. But having said that, if you're allowing someone to opt out of that social norm, I think it's very reasonable for a society to say, first of all, it should at least be a truly informed decision, i.e. physician counseling is important, but also a little bit of procedural effort is warranted. So there have been a lot of attempts to legislate in terms of HPV vaccinations, or have executive order-based requirements, or through health department regulations. So there have been a lot of efforts to introduce immunization requirements against HPV, but largely these laws haven't been successful, or these requirements haven't been successful, with three notable exceptions, which is Virginia, DC, and Rhode Island. Rhode Island is a little bit more recent, and hoping to see a more robust assessment of their requirements in terms of the impact of their requirements. But there was a really nice assessment of what happens on HPV vaccination initiation amongst female teenagers by state school entry requirements. And it turns out that the Tdap vaccination rates, Tdap requirement and MCV requirements evidence that adds more details to it, and I'd be happy to discuss that, in the next part of this session. So when there was an assessment of why states are not adopting these requirements, there were different factors, and can be broadly we can broadly categorize them into factors specific to HPV vaccine and related to policy making around vaccines. First of all, when the vaccine was relatively new, there were a few concerns around mandates related to that aspect. the fact that HPV is an STI, people have certain concerns around mandating that, and something related to that, which is that it's not transmittable in the classroom setting. I would argue that broadly speaking, maybe in later years, it is transmitted in educational settings, for example, in colleges, etc. But at least in the school setting where it's more proximal, then you could argue it's not transmittable compared to things like measles and pertussis. There's discomfort in terms of vaccine manufacturers' involvement, and I think we can talk about it a little bit more. I think when there is advocacy for even reasonable infringement on personal liberty, it's better suited to come from folks and entities that are separated from manufacturing, irrespective of the evidence of an intervention's effectiveness related to mandates. Price of vaccine was a consideration in terms of sort of burden on the health system and the individual. In terms of relevance to policy makings, there is some concern around government coercion or perceived government coercion. There is some activism that plays a role into developing an environment against vaccine requirements, and then the nuts and bolts of the policy-making process also adds some challenges to adopting these requirements at the state level. Having said that, there's some interesting data, again, coming back to the Goldilocks approach that I particularly like. When you ask parents in terms of their support for school entry requirements, the general agreement with these requirement-based laws is modest, lukewarm. Less than half agree or are neutral in terms of these requirements for HPV vaccine. But when you say that whether it's okay to have these laws, if parents can opt out, and again, these requirements with an exemption, but having an exemption which is rational, that tilts the balance of convenience in terms of vaccination versus non-vaccination, may be a reasonable approach to consider, at least based on the current evidence. Having said that, there needs to be a lot more evidence in terms of our assessment of the effectiveness, utility, and unintended consequences of these requirements. So I'll stop here and would be happy to take questions, etc., and have some discussion around it.
All right. Hi, Saad. Thanks for weathering the stay over at LaGuardia Airport and now our technology issues. I'd like to make just a few comments just to contextualize this in HPV vaccination, and I really appreciate what you covered so far, but things to sort of bring us a bit into the room as well. So let me go through these, and then we'll also go through a Q&A process as well. So I think one of the main take-homes from Saad's talk is that, especially from his recent Nature paper that has gotten quite a lot of media attention, is that we do mandates after all else succeeds. So we do a lot of stuff, and then it succeeds, and we get rates that are pretty high, and then it's a good time just to think about mandates. Second thing, a lot of Saad's data that he was presenting on mandates or school entry requirements, those data are for childhood vaccination. So toward the end, we saw a lot more on HPV vaccination, but it's good to keep in mind that a lot of what we know about school entry requirements is specific to younger age children, and they are quite robustly effective. Now, in the context of HPV vaccination, whether they work or not is a topic that's been going on it's been an area of debate for quite a while. So as I look around the room, I see various of us who published a paper at one point or another saying no, yes, no, yes. And having published one of the no papers, and we saw it there, I'd love to point to you, Greg, if you don't mind, if you can come up to the mic and basically just give us the two-sentence summary of what you found in your most recent analysis of the impact of school entry requirements for HPV vaccination. And as I recall, this analysis brought us all the way up to current data, including Rhode Island, which the previous ones had not. And as I recall, you also framed this as the difference between good mandates and bad ones.
Yeah, so it actually only looked at Rhode Island, since Virginia's mandate is a non-mandate mandate, where the language basically says all parents shall have their daughters, again, it's not a gender-neutral mandate, shall have their daughters vaccinated unless they don't want to. So that's about as easy an opt-out.
And a quarter of the people opt out, yeah.
Yeah. So, what we did in that analysis was we looked at NIS teen parent report data, and we used a difference in differences approach. So we used Rhode Island as the experimental group, if you will, and the rest of the states as a comparison, and then looked at what happened after 20. I don't remember when they implemented it. Someone help me? Someone from Rhode Island? No? 20, maybe it's, I don't know, I think it was 2015, was
or
it?
2016
2015 for Rhode Island.
Yeah, 2015. So what we found, at least with the NIS teen data, was that male vaccination took a sharp turn upward in Rhode Island compared to the rest of the country. There was not the same change in slope in female vaccination. I mean, the part of it, the way we explained that, is that female vaccination was already really, really high. So it may have been a ceiling effect. But we had pretty good evidence from the parent report data that the implementation of that school entry requirement did result in an increase in vaccination of males. We've subsequently done, which we're going to be submitting for publication, an analysis of the confirmed, physician-confirmed administration, and it echoes that as well. So it's pretty good evidence that the school entry requirement implemented in Rhode Island in 2015 has had at least an effect on the increasing rates of male vaccination. And Debbie and I have been discussing the question of whether the peak age of vaccination in Rhode Island for males and females may have dropped because of this. That we don't know yet, and it's hard to study that with NIS teen data. But
Registry data, maybe, okay. Yeah, it's very helpful. Thank you very much. Okay, so to bring us up to speed then, we at least have a positive signal for males. For females, maybe there's something there, maybe the power, we don't have the right powered study. It didn't seem to hurt. In the other two states, at least in the analysis that we did, Virginia and Washington, those were two other places where requiring HPV vaccination appeared to undermine some other rates. So it the spillover there may be negative in requiring HPV vaccination using a bad policy. People get in the habit of opting out from one vaccine, they opt out from others. Okay, so that's the next point that I want to check in on. Now, an additional point. Globally, the way that the countries with the highest rates, they've done it in schools. There's no question about it. We know that. And there's a nice paper that shows, for example, the difference between doing school-located vaccination and clinic-located vaccination in Canada, 70% versus 35%. It's double the rate. So here in the U.S., we're doing something tough, and yet it is actually working bit by bit, and given our system, this is probably what we're going to have to do. We don't have the option of the voluntary school-located programs in the same way, because we don't have a single central payer, we don't have the same kind of understanding and normalization of this process, and then parent consent is also challenging. So that's, I think, another issue on its own. Another thing I'll mention is that mandates are requirements for school entry, school requirements for vaccination. There's a variety of data out there, not so common in Europe. But a lot of different kinds of requirements are there. Certain workplace requirements, also here in the U.S., there's a lot of variety in requirements. So although we're focused in on HPV vaccination, yes or no, for a certain age child, vaccination requirements are present in all sorts of places, even in places you'd least expect to see them. So I think that the yes/no question for us should be in a larger context of a continuum of what kind of requirements are available and where we are on that continuum. And then the final comments I'll make are about specifically requiring HPV vaccination in the U.S. So there are some different approaches, some broader ways to think about this. It could be a yes or no, do we require the vaccine or not? But what if we reframe the requirement Instead of focusing on HPV vaccination, we require adolescent vaccination. And the law is written in such a way that it focuses on whatever's on the schedule for adolescents, that they must get this vaccine. One of the things that we found in our school-located work is that school-located vaccination programs that focus on HPV vaccination do very poorly. They were about 10% lower in terms of uptake than school-located vaccinations programs that focused on any vaccine across the platform. So let's consider that as we're talking about this, that we could be talking about laws that would require HPV vaccination, meningitis, Tdap. Another possibility, we could strengthen the requirements for those other vaccines, meningitis and Tdap. So we could tighten up the requirements for those, or the exemptions, have fewer exemptions. And that might have a positive spillover effect. When Saad was speaking, he pointed out some data by Moss et al., the paper that my group wrote, and his voice got a little covered by the IT issues. But essentially what happened is that requiring meningitis or Tdap caused about a 5% increase in HPV vaccination. So since all states are already requiring, pretty much all states requiring Tdap, there's not a lot of movement there, but meningitis is something we could potentially create some movement on. Okay, so that was just a bunch of miscellaneous thoughts to add a little local context to all of this. Maybe what I can do right now is pause, and Saad, I don't have your picture on the screen, but I'm either your, anything that you want to maybe comment on as we, in response to some of the stuff I just ran through.
So since you don't have my picture on the screen, those of you who are hearing a voice in your head with an accent, it's me, not nothing.
And you're up now. We've got you. And you're, there we go. You try again? Yeah. Wow. Did you send an anti-vax tweet out? Because we have a filter on those folks. Maybe that's a... I'm sorry, Saad. Is there anything we can do to help?
Can you hear me?
Oh, you're back. Good.
Okay. So what I'm saying was, thanks for summarizing, the evidence, etc., and adding to it. I'll say a couple of things based on what was discussed. I agree. There's an expression in my first language that I grew up with. It translates roughly as a joyless sin, meaning that if you're going to go through the effort of sinning, might as well enjoy it. And so mandates that are half-baked, I know there's a lot of effort that takes to implement and craft and advocate for those mandates that are, for example, Virginia, etc., fall in that category of a joyless sin. So my thinking would be to have it a little bit, stronger, but still with some choice. I agree that there are certain, as I mentioned, that there are certain requirements, and I'm assuming you can see the slide from our recent paper. For example, it's a no-brainer, and it's absolutely essential to ensure a stable vaccine supply and monitor safety, etc. But I do think this is where I would amend. This is where I would clarify, my position a little bit, which is that it doesn't have to be after every last thing is tried out. It should be after access-related issues have been robustly addressed, but it can be tried out with other interventions. So it should be tried out. It shouldn't be used as a stand-only intervention, but for example, you don't have to wait for a robust registry and a reminder recall system to be fully implemented, as long as there's concurrent investment in that. So that's where I take a little stronger position on mandates, because they have reasonable evidence, and because if you do it right, they should have protections related to what we describe in our step 3, which is that ensuring that the procedures are fair, that penalties are appropriate, that there's compensation for adverse events, and so on and so forth. So I'll stop here and would love to hear thoughts from others, etc.
Okay, and I think, given the IT issues, I think we're wrapping up on time. Let me ask 2 questions briefly, and then we'll wrap it up. So how many people here think that in the remaining states and territories, we could never have an HPV vaccine requirement, school entry requirement? How many people think that? You could just, like of the remaining ones, it will never happen in any of them. So the general sense here is that it's possible. Somewhere there's movement. Okay. Now let's talk about your state, and let's flip the question. Given your state's legislature, your state's apparatus, your state's vaccination rates, your state's whatever, can your state do it right now? Can your state do it right now? How many people think that your state could do it right now? Okay, we've got 1. NIH is in the house. Doug Lowy, you didn't see that. Okay. I think that's about where we're at. We think it's possible, and we are having a hard time seeing it in our state. So I think that's a good next step for advocacy work, is trying to figure out what are the concrete next steps that we can take. And I think we've heard from Saad fairly clearly that there is optimism, that there is a hope for this intervention, and it just has to be done carefully, using some of the guidelines he's laid out, and with a sense of purpose to it. Thank you all so much. Thank you, Saad.
Thank you.
Okay, thank you so much to our intrepid speakers. We're now going to have a short 10-minute break. I would encourage you to look into your snack bags, avoid any joyless sins, go only for the really good treats, and we'll see you back here in 10 minutes. Thank you. All right, we're going to come back together now for our final panel. So again, this will be our final panel. And I am pleased to introduce a woman who truly needs no introduction. Dr. Debbie Saslow will facilitate our last panel on elimination of HPV diseases as a public health problem. Debbie.
So collectively, we have 100 years experience in HPV. So that means that you should feel very confident that you're about to hear from some very wise people, and it means we should all feel really old. Oh. So you can read in your folders the bios of these very, very, very accomplished colleagues. I'm just going to briefly say my own opinion of these 3 colleagues. So, Jane Kim is going to start us off by telling us about elimination. What does it mean? How do we define it? And Jane and I go back the longest out of any of you guys. Jane is the person who knows decision-making analysis, and cost effectiveness when it comes to HPV screening, cervical cancer, vaccination, both here and worldwide. So I'm extremely excited to have you here. She's also great to go kayaking in the complete black dark in Puerto Rico. Anna Giuliano knows everything there is to know about HPV and the natural history of HPV, and has just contributed so much in what we know about that. And when I talk to Anna, she knows everybody in addition to everything. And she's just so well connected to everybody in the HPV world, and it's come in extremely handy. So when I need an introduction to someone, that's who I call. And then Greg, you've already heard about, but Greg Zamit, who, so Anna's going to, after Jane tells us what is elimination, Anna's going to tell us how do we talk about it, and who do we talk to about it, and how do we do that differently depending on who we're talking to. And Greg's going to say, yes, and there are some barriers here. And Greg knows everything about attitudes and behaviors when it comes to HPV. So collectively, we're going to have a good conversation. Now, about a year and a half ago, all of a sudden this word, elimination, was being used with the phrase cervical cancer. And Anna had a lot to do with that, and we immediately invited Anna to do a webinar for all of our roundtable members about the science that shows that we actually can eliminate HPV cancer starting with cervical cancer. And then groups started coming out with position papers saying, yes, we can eliminate cervical cancer, both around the world from the WHO and others, from all the cancer centers, and of course ACS had to have our own as well. And so we're building out a webpage on hpvroundtable.org just on elimination, and I'm certain that after this meeting there will be a lot more on our webpage. And then, I can't see that. Oh, that must be this. So in your folders, as you know, we have these wonderful 1 to 2 page summaries. And so just refer to that for the facts. So a show of hands. What does the word elimination in the context of public health and us being here, the HPV Roundtable, mean to you? So you have 4 choices, and raise your hand if it means eradication to you. Are those synonyms to you? A few hands. Does it mean 0 cases? Does eliminate mean we have 0 cases of disease? Does eliminate mean we have close to 0 cases? And how about, does it mean we have 0 deaths? Great. Okay, so that's a great starting point. Clearly C is the winner, and I think now, hand this down.
Do you want me to just talk from here in this fireside
ahead.
chat type formatting? Well, it's such a pleasure to be here, and thank you for the invitation to come and speak to you about elimination of cervical cancer. I'm here to set the stage, including just providing some context to the formal definition, that the working definition currently set by the World Health Organization, and then as well as some projections from mathematical models. This is a large body of work, and I'm just going to give you very brief snapshots from some of our core findings, just to give you some context into how we might eliminate cervical cancer and by when in different world regions, including the US. So as Debbie mentioned, given the opportunities for both primary and secondary prevention of cervical cancer, in May of 2018, the WHO Director General issued a global call for action to eliminate cervical cancer as a public health problem. And since that call, since a year and a half ago, many both international and domestic partners have endorsed it. And so, really trying to define what it means to eliminate a disease as a public health problem is confusing. And I wanted to clarify, it seemed like a lot of people did their homework and read the handouts beforehand, but I wanted to clarify that the WHO has very set terminology, very specific terminology about disease reduction. And I wanted to clarify that before we continue to talk about elimination. So here's just a stepwise progression that shows the continuum of control, elimination, and eradication. On the far left, we have control, which refers specifically to reduction in incidence, prevalence, mortality, morbidity, to locally acceptable levels. Okay? And in order to achieve control and to maintain control, we actually have to have continued intervention measures that continue along, and we can't stop them. To the far right, the opposite extreme, is eradication. And this is referring to a permanent reduction. This is reduction of incidence to 0 worldwide. And we've only accomplished this in one instance, and that's smallpox. And as is implied by permanent eradication, this involves just no continuous intervention measures. Now, in the middle is where we have elimination, and this does involve continued intervention measures over time. There are different levels of elimination. Elimination of disease is referring to incidence reduced to 0, but in a defined geographical area. So we're not talking about worldwide. Elimination of infection also is reducing the infection by a specific agent to 0, again, in a specified geographic area. And then elimination of disease as a public health problem doesn't imply actually reduction to 0. It implies a significant reduction to low incidence or mortality. And it's also marked by setting and achieving specific and commonly agreed target goals or target definitions. And so what do we mean by that? Well, in the case of cervical cancer, the World Health Organization envisions a world without cervical cancer. That is their vision. And their current working definition for these targets for elimination as a public health problem involves a threshold target where all countries would reach cervical cancer incidence of less than 4 cases per 100,000 women. Okay? In the interim, as a more kind of intermediate goal, they've also set some intervention targets. And so the WHO has, in their current iteration, proposed by 2030 that this involves 90% coverage of girls fully vaccinated with the HPV vaccine by age 15. In addition, 70% of women screened with a high-performance screening test at the ages of 35 and 45. And in addition to that, 90% of women who are identified with cervical disease would receive appropriate and high-quality treatment and care. Okay? And so this, again, definition of eliminating cervical cancer as a public health problem involves these targets and trying to meet these targets. This map shows us just the stark disparity of cervical cancer incidence worldwide. This is by country. We're also showing this as categorized into income groups. And the dark blue region that you see there is marking countries where they've reached a cervical cancer incidence rate of 4 or less per 100,000. The lighter blue is indicating up to 10 cases per 100,000, and this is where we see the United States falls into that category in North America. And then the red region is showing 10 or greater cases per 100,000 women, with the darker region showing higher burden. And there are just two kind of major points that I want to highlight. The first is that the burden of disease is highly correlated with income. And so the lower middle income countries are disproportionately facing the higher burdens of cervical cancer. And that's mostly because of access and utilization to screening and other preventive measures in these countries. The second point I wanted to make is that very few countries have reached currently this threshold of 4 per 100,000, and even up to 10 per 100,000. And so the level of effort and resources that would be required to bring every country on our Earth to a level of 4 per 100,000 will be extensive. So in these discussions of how to make this global action a reality, we have some key questions that I know that the World Health Organization has been grappling with. The first is what we just talked about. What is an appropriate cervical cancer threshold to achieve elimination as a public health problem? The second is what combination of vaccination and screening strategies can actually get us there? Third, when can elimination be reached, if at all, for the different strategies and by country? And what is the most efficient and cost-effective ways to achieve elimination? And so in the past year and a half, several modeling groups, including my own, have been working in collaboration with the World Health Organization to try to evaluate some of these questions and some of the strategies. And I just wanted to give, before we move on to communication and barriers, just a quick peek of some of our findings from some of the projections from our models. And so what I will be showing you is the dynamics of elimination, how cervical cancer incidence rates change over time, in low-income countries on the left, lower middle-income countries on the right, for 3 different scenarios, just 3. We've evaluated many, but I just pulled out 3 because these are some of the main strategies that the World Health Organization is focusing on. That blue line that you see in the low-income graph is indicating our target of 4 per 100,000. Okay. So in the green lines, we see that in that top line, that kind of dotted line is the situation where there's no further change in the effort towards increasing, scaling up screening or vaccination in low-income countries. Our starting cervical cancer incidence rates, age standardized, is roughly 40 cases per 100,000 women. And we see that continue over time without any kind of further intervention. The line below it, which is kind of the stapled line, indicates where we're scaling up vaccination of girls only to a very high level and very immediately. Okay, and so we see that incidence curve reducing over time. Below that line, which is kind of the dashed line, includes that high coverage of vaccine for girls only, and also including a single lifetime screen among adult women. And then that bottom line, which is the solid line, is indicating that high vaccine coverage for girls, and also including 2 lifetime screens for adult women. Okay? And so what we can see here when we look at if and when we cross that 4 per 100,000 threshold, is that for a scenario of just scaling up vaccination of girls only, we actually don't get there in the low-income countries, and this is largely a function of their starting incidence rates are too high. We do, when we introduce single lifetime screening or 2 times per lifetime screening, we do cross that 4 per 100,000 threshold. But we can see that that is happening in 60, 70, 80 years, okay? Roughly around 2080 to 2090, depending on the screening strategy. Over the full 100-year period that we evaluated, we're estimating that in low-income countries that we would be averting roughly 3 to 4 million cases of cervical cancer from these strategies. Now, in lower middle-income countries, we are starting with a lower cervical cancer incidence rate, and we can see that all 3 scenarios are hitting that 4 per 100,000 threshold. And that is happening about a decade earlier than what we saw in the low-income countries. Cumulatively, over the 100-year period, we're looking at roughly 11 to 14 million cases that are averted in the lower middle-income countries. So it's achievable, but after many decades. I wanted to just quickly contrast this with the US context, where we have already adopted vaccination and already adopted screening. In addition to the 4 per 100,000 line, I've also included a threshold of 1 per 100,000 as is being discussed in various pockets in the US and policy kind of discussions. And so we are fortunate enough to be starting at a lower cervical cancer incidence rate of roughly 7 cases per 100,000 women. And this black line is actually showing us our status quo. What happens if we don't push further for vaccination or for screening? And we do see that we cross that 4 per 100,000 threshold, even under the status quo, but in roughly 20 years, in 2038. This orange line is actually showing us a scale-up of girls-only vaccination. This is only focusing on very young girls, and we see we don't bend the curve that much, and that's because we've already hit a sweet spot in terms of coverage and herd immunity in the population. In contrast, this green line is showing us a scale-up, a dramatic scale-up of screening among those who are not screened regularly in our country. And we see that for this scenario where we're scaling up screening, we're able to achieve the 4 per 100,000 threshold in 2030. And in addition, we're able to hit this lower threshold of 1 per 100,000 by year 2064. So still taking several decades. So just in closing, I just wanted to summarize some key points. The first is that the appropriate thresholds and targets for cervical cancer elimination are not clear. The second is that context matters. The starting burden of disease will greatly influence the achievement and the timing of elimination. And even in the United States, we need to keep up our efforts to ultimately hit the elimination targets, and we need to increase our efforts if we want to get there faster. With that, I wanted just to acknowledge the other modeling groups who have contributed to the projections from the low and middle income countries as well as in the United States. Great, thanks.
Oh, so we have a question.
We have a question.
Okay, so before we start the communications part of this presentation, who is a priority target audience for an elimination goal, and who should we be convincing? A, the public health community, B, government and policymakers, C, the public, D, all of the above.
So how many vote for A? B, C, D. All right.
Okay, good. Okay, well, with that.
Makes your job easier.
So, yeah, no, it made my job really easy, except, you know, I was really jealous. Doug Lowy came in with this cute little sticker that said HPV nerd, and I realized that I've been mislabeled the communication person. I'm the HPV nerd, and somehow I've been assigned the communication talk, and I think it's because I probably talk so much. Doug, yeah? No, I'm going to beg for my own sticker so I can go home with it. Anyway, thank you. And I think the reason somehow I have been in this position of communicating, and I, you know, before I really go into each of my slides, I want to follow on something that Jane said earlier. In the United States, we have controlled cervical cancer. We have. I mean, it's a relatively rare cancer if you think about it. And that word control means that we've reduced the incidence of cervical cancer to an acceptable level. And I have to say, last month, I presented that exact same definition to a congressional briefing in front of Gil Oman, who is actually a wonderful physician scientist from Michigan who was hosting the briefing on our behalf. And he said, cancer to an acceptable level? I mean, what would really be an acceptable incidence rate of cervical cancer when this is a cancer that you can prevent? So what would you ever consider as acceptable? And I want you to really think about that as we go through today, this session, and as we go through, I think, the rest of today and tomorrow. Is it ever acceptable? And when you're speaking about that, who are you speaking that to? So we have policymakers, donors, the public. So what are we trying to get them to do? We're trying to get them to provide resources so we can actually do our job better. I mean, I think we heard in this last session how much resource it takes to move a health system to even be able to access the data needed to feed back to providers to let them know where they stand. So we need those resources. And then we have the scientific and medical communities. How do we convince our providers, all of them at every level, that they should be advocating that their patients receive vaccine? What is that going to take? And typically, those are the kind of groups that require some sort of data. So I actually am not going to show you any data in this talk, which is a little scary for me. So no graphs, no curves. So why are we talking about elimination here in the United States? Why is elimination the message? And it really comes down to one thing. It really comes down to an urgency, creating an urgency to save lives. Because there is never an acceptable level for a woman to die of cervical cancer. Every 2 minutes, and I'm showing you now data for the world, so it's less in the US, but I want you to think about what's happening in the world. Every 2 minutes, another woman is dying from cervical cancer. This is a preventable cancer. Is that acceptable? It's not for me, and I don't think it is for anyone who is sitting in this room. In the United States, there are over 13,000 women who will be diagnosed with cervical cancer in 2019. In essence, almost a completely preventable cancer. And of those women, over 4,000 are actually going to die of that disease, die because of their diagnosis of cervical cancer. Now, here in the United States, we are creating advocacy, and many of you in this room have been a big part of helping to get that message out, to really advocate that we in the United States take on the goal of eliminating cervical cancer. Now, there are many countries who have already made that declaration. Jane presented some of those in a prior slide that WHO has put together. Australia they came out first. And I have to tell you, it's really driving me crazy that Australia is doing this, because I really think that we can do this and we can make a statement if we push hard enough and get the resources and get everybody activated, then maybe we could be the first country to reach that goal of 4 per 100,000. I mean, you saw what happens with the models if we do nothing more than what we're already doing. But if we just can move the ball down the field a little faster, we could probably make this statement. Well, and it's not just Australia. Canada, our neighbors to the north. Oh, what about Rwanda? Didn't we hear about Rwanda at lunch? It's actually Bhutan that actually has a higher vaccine coverage. But, gee, Rwanda and Bhutan. Rwanda has made the statement that they are taking on this goal and plan to achieve the goal. So how do you communicate all of this? So right now in the United States, our cervical cancer incidence rate is around 8 per 100,000. But recognize that we have a very diverse country. There are states in the United States that are very close today to the incidence of 4 per 100,000. They happen to be in Jane's neighborhood in New England. I think Minnesota. Where's North Dakota? North Dakota, you guys are doing really well. We have amazing success in the United States. But then we also have major challenges. I won't call out the states. My friends are sitting here. We have major challenges. But if we can get everybody on the same road, the road collectively starts at 8 per 100,000. 4 per 100,000 is the next step. And if we push to achieve what we've already said as national goals for each of the different components, we probably can get to the 4 per 100,000 by 2030. But we're going to have to push. And if we continue to push and we continue to run our interventions, vaccination and screening, over time, we probably could achieve the goal, which I think everybody raised their hand for, which is almost zero, as close to zero as possible. So less than 1 per 100,000. So now you're talking to the providers. So what are those tools? We've said this over and over again. We have the tools to eliminate HPV-related cancers. I'm going to focus primarily on cervical cancer, because here we really have, it's a three-legged stool, and you all know what that is. Vaccinate, screen, and treat. Pretty simple, right? We're doing it. We're already doing it. What we need to do is accelerate our progress in eliminating these cancers, again, starting with cervical cancer. We need to push that. After decades of cervical cancer incidence and mortality rates declining, we've flattened out. We're like at a standstill. We can achieve the goal if we increase the rate of vaccination and increase the rate of screening and treatment. So where are we right now? Now, I know the data, I think that the data for 2018 have just been released. Is that right?
Tomorrow,
1 o'clock. Tomorrow? Okay. I was on vacation. I was literally in the middle of nowhere in the Pacific, so I was like, I wonder if the rates came out. So this is for 2017. National coverage at 49%, and you can see the variability that you've now heard about for the country. Our goal is 80% by 2020. We really need to make a strong push. And what about the screening? Well, even our screening rates are falling short, and you can see again the diversity in screening rates. Our goal is 93% for the United States, and we're at 80% coverage with a lot of variability. Again, we need to do better with this. We can achieve that finish line. I'm really convinced of it, and I think all of you here, I'm sure, are convinced of it. It's a matter of communicating it, because Yes, we want to increase screening rates. Yes, we want to increase vaccine rates. But the reason we want to do that is because we want to prevent women and others from being diagnosed with these cancers, and we want people to not have to die from these cancers any longer. So that's the communication spiel, for the most part.
Great.
Thank you.
Thank you.
So I get to throw cold water. It's like, yes. Actually, I don't think that's the point of this, and I really want to build on what Jane and Anna have been talking about. But I am going to talk about some of the barriers to achieving these goals, because that's sort of, in part, what this conference, what this meeting has been about, is sort of how to overcome those barriers. You've seen my disclosures before. They haven't changed since I gave my talk this morning. I think I've lost funding from somewhere, but but that happens every day. So we, I want to absolutely agree with Anna. We have the tools. We've had the tools for some time, but what do we need now to finish the job? And when I wrote that, I was reminded, this is a sort of off the topic a little bit, but Winston Churchill, in a communication with FDR, said, "Give us the tools and we will finish the job." So we have the tools, but there's still more to be done. So what we need to do to finish the job is really overcome barriers. And I'm going to focus really specifically on the U.S. because, unfortunately, we have an array of barriers that a lot of other countries don't have, including Australia and Rwanda and Malaysia, countries that have achieved really high rates of vaccination. And I'm going to focus mostly on vaccination and less on screening. Because we have so many barriers, there's a lot of work for all of us to do. So I don't think any of us who are studying these and trying to find ways to overcome these barriers, unfortunately, I don't think we're going to be out of work anytime soon. But I wish we were. So I'm going to just talk about some of the categories. You all probably know all of these, and we've talked about them. But certainly there are barriers at the individual level. Individual health beliefs, lack of knowledge, and we have this little person thinking about all the kind of things that come up and things we hear from parents in terms of why they don't want to vaccinate their kids. And so we all, many of us here are working on developing ways to effectively address lack of knowledge and misguided beliefs about HPV vaccine. And I should say right away that these different sort of categories I'm talking about are not isolated. There's a lot of dynamic interaction. So I may be talking about individual beliefs, but those are influenced by a lot of other things, including sort of family and social group norms and beliefs. And my family wouldn't approve. Does it fit with my religion? Just as a basic statement, there is no religion that has any tenets where it says, "Thou shalt not vaccinate against HPV." What would my friends think? So some of the group influences, including now, so importantly with social media, can have such a powerful effect on people's attitudes, beliefs, and understanding. The healthcare system, and this is, we have a uniquely messed up and complicated healthcare system in this country that we have to grapple with and think about as a barrier to be overcome. And some of the issues have to do with healthcare provider communication and we've talked about whole office communication, like the consistency of messaging across all office personnel, access to healthcare, particularly in rural communities. Do we have adequate benchmarks, HEDIS measures that are actually being implemented, and with those expectations being set? Are enough systems using standing orders? Are enough systems using reminder and recall systems? All of these things are important for the healthcare system to operate effectively to vaccinate as many children as possible. State policies are an issue, and I have here a map of the United States all kind of floating around because each state has its own approach to vaccination policy. and not just policies in terms of what's required for school entry, but also there are informational requirements from state to state that vary. So it's confusing. It's a huge barrier, I think, for us to overcome. We heard how there's tremendous variability both in vaccination from state to state, but also in disease incidence. It just adds to our challenge. It's almost like we have a bunch of little countries within our country, not just around vaccination. Obviously, we see it with a lot of things. And then there's nationally politics and policies that many of us are, working and advocating to change. But we have, we have national leaders or candidates who will say untrue things about vaccines in general or about HPV vaccine, and it gets a lot of coverage. Again, when that happens, that's another barrier. It's another kind of issue that we have to keep in mind to deal with. And of course, social media, which I mentioned before, but is a powerful influence, and it's one that knows no boundaries. So people all over the world can affect how people in the United States understand or misunderstand vaccines, and vice versa. So, you have huge dissemination of misinformation and fear, cyber attacks on HPV vaccine advocates, creation of false norms. So people who belong to particular groups might think that it's more common to not vaccinate than to vaccinate, or that HPV vaccine almost always causes problems. And there's the creation and the magnification of conflict, which has actually become highly politicized. As we've seen in the bottom article, the American Journal of Public Health article that came out last summer, which showed that Russian bots have inserted themselves in the vaccine debate because it's a hot topic, and that's one of the elements of their strategy is to increase conflict. And the upper article is a report of Todd Wollen's practice, where they had posted HPV vaccine supportive videos and then got attacked from people in a concerted manner from all over the world. So all these factors, as I mentioned, are interconnected, and so part of the barriers we have to overcome is really to think about, what do we need to do to address these barriers? And I think we can't be focused on only kind of addressing one of these areas. There are enough of us who are passionate, and we in the United States should have the resources so that in addition to addressing individual issues, we should be able to address the barriers in healthcare, in personal and parental factors, the social environmental factors, institutional and political factors, and to reduce some of the logistical challenges, again, thinking about particularly rural and poorer communities. So we do have the biomedical tools, but we have to keep working on the political policy, social behavioral tools so that we can overcome the barriers and finish the job, as this cat is showing us the way. Thank you. We have a final question. Let's see if you do as well as you did on the...
There's no right answer to this one.
No, that's right. So, yeah. So this time be really honest. Which barrier is your organization most likely to address? So raise your hand if your organization is most likely to address individual and family beliefs. A few there, yeah. A few hands, yeah. And social norms, social media. Some of the same hands, because I think a lot of our organizations do multiple things. Health system barriers. Excellent. So that's a large proportion of us, which doesn't surprise me given the Roundtable's mandate. Policy barriers, state and national level.
Great.
So all of these are represented. Obviously, health system barriers have the largest participation rate, but it's good that we're doing everything here.
What's the next slide? So I'm going to ask just a couple of questions to start us off, and then people can come to the microphone. Can any of you comment on, we've really focused on cervical cancer, and that makes a lot of sense for a lot of reasons, but is there any talk about elimination of HPV cancers, starting with cervical cancer? Is that something that can we talk about prevention of vaccine preventable cancers?
All right, because I study HPV natural history in men, but she didn't mention that, but that's, so we have 6 cancers that we know of that are caused by HPV, and one of them we know we have multiple interventions, right? We have screening and treatment for cervical cancer, and we can vaccinate to prevent cervical cancer. The other cancers, while there are research groups who are studying ways to screen, for instance, for anal cancer, to prevent anal cancer, right now we do not have a routine method or anything in standard clinical practice to screen for those cancers. So really the only way we can prevent the other HPV-related cancers is to vaccinate. I was going to talk about it, we had a limited amount of time. The issue is, if it's only a vaccine strategy, which, my personal belief is that we can achieve the elimination of those cancers as well. And in fact, many of those cancers occur at a very low incidence rate to begin with and are below the 4 per 100,000. But I would like to invoke the, getting to zero concept for those cancers. We probably can achieve it. It just is going to be on a longer timeline, because all we have is that one intervention. We don't have that 3-legged stool that I showed you for cervical cancer. Mark Jitt, who's one of the modelers that has been working closely with Jane and others, has a really wonderful publication showing what it would take to eliminate HPV 16. So it actually looked at 6, 11, 16, and 18 elimination. The reason I mentioned 16 is that's the really bad player for all of these cancers. And it's also the hardest of the virus types of HPV to get rid of. And he actually presents a compelling argument that you can eliminate and eventually actually eradicate HPV 16 infection. And if we can do that, then we get rid of all of the HPV-related cancers. In a country like the U.S., where we vaccinate both males and females, I think we do have the opportunity to speak about it. But right now, it's only a minority of countries that are gender neutral, have gender neutral vaccine policies.
And Greg, you showed some nice maps. Can you comment on equity? And so one question I have is, we have some states that are really close to 4. If they ramp up their efforts, and then we have these other states that are really far away, are we risking making disparities worse?
Well, I don't know that it would make disparities worse, and I would hate to see states that are doing a great job, to say, hey, wait, hold on, let some women die of cancer in your state so that it'll be the same as Wyoming or whatever. Right. So I guess I see the issue being perhaps more that it creates maybe some policy challenges, so in terms of screening and how devoted a particular state might be to screening. I also see an opportunity, which is to perhaps try to ramp up some competition. To speak to one, I don't want to name, like you did, who was it who didn't want to, you didn't want to name states, right? Or someone didn't.
I didn't.
You didn't, yeah.
I'll just get started. I'll look in certain directions, including mine.
But to really, maybe to broadcast that message is, Connecticut has, so I'll name a state that's very close, right? So Connecticut has, reduced cervical cancer almost to the point of elimination. Why can't we do the same in Oklahoma, Indiana? I can say Indiana since I'm from Indiana.
Yeah.
Florida.
I would say that, in a lot of the discussion, within WHO that I was privy to around this definition, this formal definition. There's a lot of push and pull in terms of, are we kind of shooting ourselves in the foot by governing this elimination goal as a absolute rate? Because again, you know, your ability to get there and when you get there is going to be very much dictated by where you start. And so it creates this already a disparity in terms of how much resources, and usually it's the places with the lowest resources that have the highest burden. So you're already taxing them too much. There was also discussion around the relative reduction. You know, can we use that as a goal so that each setting, each country, state, whatever, could serve as its own benchmark? And I think this is actually where some of the interim kind of intervention goals and targets come in handy. I mean, for the weaknesses that they also introduce, I do think that can, you know, we can all agree that we're going to, at every state, try to get up to 90% vaccine coverage. And whatever that outcome ends up being at that state in terms of what level you get to, 2 or 4, or whatever it is, at least we can agree upon some of those intervention measures as intermediate, this intermediate kind of step towards elimination.
Questions from the audience? If you have a question, come on up to a microphone. Jasmine?
Hi, Jasmine Tiro, UT Southwestern. Debbie, thank you so much for bringing up the equity argument, because that was one of my questions to all of you, as well as kind of from the 3 perspectives that you took this. From a modeling perspective, should we be showing absolute overall versus stratified? Should it be stratified by state, by race, ethnicity, by insurance status, by income? You know, where are we seeing those lags? Where do we see the barriers differing in terms of our vaccine screening and treatment strategy? Because the lift, I think, is very different when you think about the different subgroups. And if we don't have that data, we can't then motivate to say who is being left behind, because I think that is a tragedy here in the United States, the inequity and the lack of equal distribution of these interventions for all of these important behaviors. And so I think all of those things need to be addressed from all of your perspectives to make sure that we get all of the audience groups and stakeholders motivated around elimination.
Kathleen?
One of my concerns is that, for example, you gave the example of the state of Wyoming. One of the sessions I was in yesterday talked about rural barriers. Wyoming is a rural state. Mm-hmm. For all intents and purposes, so is Mississippi. Yeah. And we need to think outside of the box and find ways, which is what our group was doing a really good job. You need to get with those 2 ladies because we were working to look outside of the box for ways that we can implement immunization in areas where there's far distances, fewer providers, fewer resources that say, yes, I'll pay for that vaccine. A lot of those things aren't there. And so you see a dip in rates, not because people are saying, I don't want to do it, although there are some little gaps, but that happens in every state. But we need to look at different options, different ways to look at things so that we can continue to get those rates up.
Yeah. I just, if I may make a comment about both, what you raised, Jasmine, and I'm sorry, I don't know your name, what you raised about, we do have data nationally that clearly indicate that individuals living in rural areas have lower rates of not just vaccine coverage, but screening and treatment. And I want to emphasize what Jane said in her first talk is how essential screening and treatment will be for the United States for us to accelerate achieving this goal. We also have really solid data showing that racial ethnic disparities in the incidence of cervical cancer and the rates of screening and treatment. And they also vary by age group. So one of the things maybe we can do collectively is to understand our own data and look at it very carefully so we know how best to target the few resources we do have to have sort of the biggest bang for the dollar in achieving this goal.
Last question, Sharon.
My name's Sharon Helmutson. I'm from AAP. I would like to know more about dormancy or latency and how much we know about the natural history, that scientists are certain about the natural history of HPV, and does that vary by body site? I know so little about this. I'd like to hear you talk about that.
Natural history. That's natural history. Yeah. Okay. So most of the information we have about natural history is our data coming from cervical studies, obviously among women. And I think for a very long time we thought that how, let's say, HPV-16 behaves at the cervix is how it'll behave at every other anatomic site and also among men. And I think what we're learning now through multiple studies around the world is that the same virus may have a different natural history at different anatomic sites. And I don't know how much of it is it's a male-female thing or it's just really an anatomic site issue. So for instance, in our own studies where we looked at 3 anatomic sites just among men, same behavior, same sexual behavior of men, everything else is the same. And you find a completely different prevalence of infection by anatomic site and a very different rate of progression of infection to disease by anatomic site. And so I think there are still a lot of questions that are out there about what the natural history of HPV is at, let's say, the oropharynx versus the cervix in a woman, or oropharynx versus anal canal in men. And that's something that we really require more research, continued research, to help inform then what we can do for prevention. And when I say prevention, not just vaccine prevention, but also for screening, early detection, for those individuals who didn't get to benefit from vaccine. So I don't know if that completely answered your question. Latency is a very difficult question for us, and we have really vigorous fights over, is it possible to have reactivation of infection or not? And if it is, what % of all infections reactivate? It gets very heated on the podium, let me tell you.
And also, what are the clinical implications of a reactivated versus a new infection? Does it make a difference that it's been lying dormant in somebody's body and reemerges? Is that important? Is that risk of cervical cancer or any other cancer different than somebody who has a newly acquired infection? And I think the data are slowly starting to emerge around that, but it's still very uncertain.
Can we take 2 more? Go ahead. Marsha?
She was here first.
Rebecca?
But I am going to go follow this conversation.
Yes.
Mine's more unrelated to that. Oh, okay. Then I'd just like to say that on the latest studies that I've read, that anal cancer is on the rise with postmenopausal women, like myself, who are not having new sexual partners. So I don't know what that tells you about when we've been infected. And the women I know in their late 50s aren't having new sexual partners either, even when they get divorced, because most men want young women. So it's just a fact. So I feel like we should, as gynecologists in the room, maybe be on the lookout somehow for postmenopausal women possibly being at risk for anal cancer. I don't know about cervical cancer, but so I guess what I'm saying in terms of this latency thing, it doesn't seem like postmenopausal women are going out and having sex and getting new infections. So just a thought for any scientific minds in here, because I'm just a lay person.
That's actually a complicated question. So if you study men and you look at sexual behavior across the lifespan, it's much more sexually active than, okay, yeah. So I always argue against reactivation, having studied men in 3 countries for a very long time, and I think a lot of this is new infection. The latency question, and I think what you're asking is how long does it take after you're infected for that cancer to develop? Is that the question you're asking? Right. Well, so one of the things is how long it takes from the virus to how long does it have to persist before it progresses to a precancerous lesion and then progresses on to an invasive cancer? And that may be different at each of the anatomic sites. So that's what I was hinting at. So the median age of diagnosis of cervical cancer is women in their 40s. The median age of diagnosis of an HPV-related oropharyngeal cancer is 60. And I think I'd have to look at the anal cancer data. I don't remember it offhand. But it's occurring at older ages. So is that new infections at older ages, or is it an infection that was acquired in the 20s and it just took 40 years to develop into a detectable cancer? And those are questions that we don't, right now, I don't think we have answers to. There is a proportion of infections that likely reactivate. That evidence comes from the HIV community, where certain these individuals did not have any sexual relations for X period of time, and what we're finding is evidence of cancers developing. So the thought is that that's evidence that reactivation can occur. But I want to emphasize that's in an HIV positive population, so the immunology is very different.
And Rebecca.
This is more of a comment than a question, sort of going back to disparities in allocation of resources. Several of us in the room right now are working on the ASCCP consensus risk-based management guidelines, and the strategies will allow us to risk stratify much better, such that women who are truly at low risk, which we can prove by improved knowledge of natural history and being able to really calculate what an individual woman's or patient's risk is at the time, screen those women less intensively and really concentrate resources on those individuals who have past history of cervical intraepithelial neoplasia, past history of high-risk HPV infections, and really be able to surveil those patients more closely to hopefully prevent any cases of cancer development.
I have a comment about that. I'm sorry, I can't help myself. That's why I keep getting the communications talks. But the issue for me, having worked in diverse communities, and it really started for me at the U.S.-Mexico border in very rural areas, and you can imagine with very poor access to care. It's really the high-risk women, I think, are women who don't have access or aren't accessing care. That is the highest risk group. And we've got to figure out how to identify that population, because those are the women who are developing cervical cancer.
But yeah, you can't manage what you haven't detected through screening. That is
right. But
the first step.
So how do we get them access to care or contact with the healthcare system? I mean, we know with the Affordable Care Act that screening is covered, treatment is covered. So is it really an access, or is it a knowledge, or is it there's something about us connecting with these communities? Who are they, and how do we connect with them so we can prevent those cancers?
So I'm going to make the last comment, which is that there's a comment box next to the coffee and maybe in other places. If you have a question or comment that we did not get to, please write it on a card and put it in there. And I have a question for you that I will ask you to put into that comment box, which is, what role, if any, should this HPV Roundtable have in the topic of the path toward elimination? So if you have thoughts about that, go ahead and put that in the comment box. And let's thank again this amazing panel.
All right, thank you to our panelists. We'd like to take just a few minutes now to hear from Greg Zimmett about a resource that he's developed for all of us to help us in our work. And I can dismiss the other panelists. Thank you.
Thank you. Try to leave you all alone.
I can stretch out now. So just in case you haven't had enough of me, so I just wanted to, this special issue of the journal Human Vaccines and Immunotherapeutics was just published, and fortunately just before this meeting, so I think there are a lot of topics that would be of interest to people. There are like 20 copies that I was able to get shipped here. They're huge and heavy, so even 20 copies nearly did me in carrying them. And there's I think some postcards as well. It was a lot of work, but I think it's a good issue. I'll have to rely on other people to read it to tell me. But it covers a lot of the topics that we've talked about here: social media and the internet, policy issues from various perspectives, interventions, research on knowledge, attitudes, and behaviors, but I think with a somewhat new twist. Looking at alternative settings for vaccination, issues of HPV prevalence and incidence and type distribution and the implications of that for vaccination, several articles on oropharyngeal HPV, and then just a grab bag of some additional articles that I couldn't figure out how to categorize. And do want to acknowledge my co-editor, Nosa Osazua-Peters at University of St. Louis, who worked with me on assembling these, mostly inviting people and writing the editorial. But just wanted to let people know about it. Thanks.
Great. Thank you so much, Greg. All right. So we are now towards the bottom of what has been an incredibly full agenda. And before we wrap up, I'd like to take just a few minutes, I promised just a few, to reflect on some of the themes of the day. So what did we hear? A lot of what we heard was about the primacy of the patient-parent-provider relationship. From a public health perspective, primary care teams, including physicians, nurses, and their staffs, are truly the heroes of the healthcare system. The preventive services and counseling that they deliver is one of the foundations of population health. And we heard very clearly today that primary care teams have a difficult job, that our interventions to increase HPV vaccination have to support them, that our goal, whether we're in research or in practice, should be to make their jobs easier, or at least not more challenging. According to our panelists, we can do this today by understanding the context of clinical care, that HPV vaccine is only one of many, many priorities competing for provider time. Perhaps most importantly, we heard about the need for communication strategies that help providers maintain families' trust and better meet their communication needs. So both Lillian and Marcia underscored the importance of this goal. Annie, Laurie, Parth, Jasmine, and Greg all spoke to the need to think separately about the initial introduction of adolescent vaccines, which should be presented in a presumptive way that, as Rebecca would say, expects a yes, and contrasting that presumptive approach with a more tailored, personalized, in-depth discussion that may be needed when parents express hesitancy. Jason Turk described this moment as one in which parents are making themselves vulnerable, and that our communication interventions need to recognize and help providers navigate that moment. We also heard about health system strategies that we can use to support our heroes in primary care. So Marcy, Andrea, Jason, and others suggested the need to partner with vaccine champions within healthcare systems at both the clinical and the executive levels. This same panel encouraged us to think beyond the role of physicians to nurses and other important members of the healthcare team. We also heard about the need for high quality data, so especially provider level data to drive practice improvements. For some systems and states, this can be a tall order, but as Jane Zucker pointed out to me during a break, for some places, clinic level data is already something we have and should use, and that can come from EMRs or through state vaccine registries. We heard about the importance of providing meaningful incentives to motivate provider participation in HPV vaccine improvement efforts, which, as Rebecca noted, can range from MOC credit to donuts. Her experience suggests that these incentives can help us get in the door, but it's really earning providers' respect and buy-in that will motivate their continued participation. In all of our clinical interventions, we discuss the tension between implementing promising practices that we may have now versus waiting for those best practices. We know that implementation science will continue to play a really important role in our research to understand how to improve HPV vaccine uptake. Finally, our afternoon speakers, including Saad, Anna, Jane, Greg, and Noel, helped us to understand how our clinical interventions take place in a really complex policy environment. And we should continue to think about how we might use school entry requirements and campaigns for the elimination of HPV disease to create a pro-vaccine environment, one that will support providers in recommending HPV vaccine and also parents in accepting it with confidence. So we'd like to continue these conversations tonight and tomorrow, but I'll pause here to touch on a few last administrative issues. So before we adjourn today and prepare for our wonderful dinner event with Doug Lowy at the Georgia Aquarium, I'd like to ask you to complete a very, very short survey. If you look on your tables, you can find the link, which is also here. And if you could use your phone to take the survey, whether you're participating here in person or joining us online, it will take you less than 90 seconds, and it will give us a lot of valuable information about the day and how to move forward. I want to thank each of you for following the trail markers we set out today. I thank you for the commitment that you have and for your participation. And for those watching via the live stream, thank you for joining us today. Just a reminder, the meeting materials, including the evidence summaries and the meeting recording, will be posted to our website, and you're encouraged to share these resources with your partners. If you're headed to the aquarium with us, you'll find the address on your meeting agenda. You may want to meet up, walk to the aquarium together. It takes about 10 minutes and would be a great time to continue to discuss these themes, school entry requirements, the goal of elimination, and on and on. So with that, I'd like to conclude our program for the day, and I look forward to seeing everyone tonight at dinner. Thank you.